Our first order of business will be a presentation on social services budget related to KanCare, and we'll recognize Megan Leopold with Legislative Research. Thank you for being here.
Good morning.
Morning.
All right. Dayton and I are going to provide for you what I would call a very bird's eye view of the KanCare budget. So we're going to cover a variety of facets of the budget in a pretty broad fashion. And I'm going to start the first slide with an overview of the budget process. The budget process really begins in September, and that's when the agencies submit their budgets to the Division of Budget. And these are the agency budget requests. The two budgets that contain KanCare funding are KDHE and KDADS. From the Division of Budget, the governor makes funding recommendations based on the agency's requests, and then the governor presents her budget to the legislature. The budgets then go to subcommittees. In the House, the KanCare budget and KDHE and KDADS go to Social Service Budget, and in the Senate, they'll go to the Human Services Subcommittee that sees that budget. When the budgets are presented to the subcommittees, there are three parts, generally. The first is KLRD providing an analysis of the budget that compares the agency's request to the governor's recommendation. Then the agency will speak on their budget and answer legislators' questions. And then there will be public testimony from outside groups. Finally, the budget committee chairs report their recommendations out to House Appropriations and Senate Ways and Means. And from there, those two committees put a budget, a state budget as a whole. They pass it out of committee, and it's sent to Committee of the Whole. The recommendations of the House and Senate are recorded in the appropriations bill. The changes that the legislature makes generally fall into three different categories. The first is ongoing funding. That's funding that is put into the budget in 1 year and continues into future years. The second is one-time funding. And the third is proviso language. And this is language that generally affects the way money can be spent or policy. And these go into the appropriations bill, but they're only active for that 1 year that they're in the bill. The most common type of changes that the legislators make, that the legislator makes, are for ongoing funds. The ongoing funds generally fall into two categories when you're looking at KanCare. The first is the expansion of existing services. So some examples of this are when the 2023 legislature added funding to extend dental coverage to include dentures and partials. Another example is when the 2022 legislature added funding to extend postpartum coverage, and that extended it from 60 days to 12 months. So these changes became part of the ongoing KanCare program. The other type of ongoing funding that is commonly added is for increasing rates. Examples of that are when the 2024 legislature added funding to increase the Medicaid reimbursement rate for ABA, or Applied Behavioral Analysis. And then another one is when they added funding to increase physician provider codes in the Medicaid program. So this funding is absorbed into the KanCare budget and continues into future years without the legislature making any future or any other changes. The second type of funding that's included in the appropriations bill is one-time funding. This is much more rare, but it does happen. And some examples of this are when the legislature added funding to to add the Medicaid add-on for nursing facilities. This was included as one-time funding in one fiscal year, and then the legislature decided to continue it for another year. Another example is when the legislature added one-time funding for grants to increase wages in the 14C settings. The third example of changes that the legislature makes in the appropriations bill are budget provisos. These are language that is added to the appropriations bill and applies for that year. Some examples are in the past, the legislature added a language that required KDHE to study required billing codes and costs of providing remote non-stress ultrasounds and tests. They added language to increase the hospital provider assessment. They've added language to adjust the eligibility guidelines for the CHIP program. And they added language to put a cap on the lottery vending machine revenue. So while these budget provisos are only in effect for that appropriations, for the time period that is covered by that appropriations bill, or as it's stated in the bill, the governor will at times continue to include these provisos in her recommendation. So for example, the CHIP eligibility guidelines, those were added, that was added by the legislature, and then since that time, it's been included in the governor's recommendation, so it's continued to be in effect. Within the appropriations bill, each agency has its own section. And in the KDHE budget, the changes are made to, the general changes that the legislature makes are in the areas of administration or medical services. The vast majority of them are in the medical services funding. But as a reminder, the KDHE budget does oversee the administration of KanCare. So that's the managed care organization oversight, rates, the actuarial services that help set rates that guide that process. And then the MMIS system, which is the overall system, the database that includes all of the information about payments to providers in the MCOs. And then the medical services included are the medical part of KanCare. So the waivers are covered under KanCare, or I'm sorry, under KDAD's data, and we'll talk a little bit more about that. And then Children's Health Insurance Program is also covered under KDHE. On the next slide, you can see a breakdown of the healthcare finance expenditures within KDHE. So this does include CHIP. This is, you can see that the vast majority of the spending goes toward the Medicaid assistance, and the assistance portion of the funding is that goes to the services that are provided. So it's the funding that goes from KDHE out the door and to pay for services that are provided to individuals. You can see about 5.8% goes toward Medicaid funding, and then a much smaller portion goes toward the CHIP program. As you all know, Medicaid is a joint effort. The funding for Medicaid is a joint effort between the federal government and the state government. And generally, the ratio of payment is about 60% federal government, 40% state government. This does fluctuate from year to year, but it's a pretty small amount. And it generally hovers around that ratio. You can see that in fiscal year 2023, the healthcare finance expenditures were $3.5 billion. That's what the chart represents, is the all funds. But the SGF breakdown would look very much like that because the percentages are very much in the same ratio. And the SGF expenditures were $626.7 million. Now, if you were to do the math and divide the 626 million by the 3.5 billion, it would not come to 40%. So that is because the SGF portion is not the only state funding that goes to make up that state share. We also have several fee funds that go in to make up that state share that adds up to the 40%. Some of those come from drug rebates. Another big one is the privilege fee that's paid by insurance companies.
Megan, while we're on this slide here, so when we're looking at the 23 numbers, this doesn't include any Medicaid that's in KDAD's, correct?
Correct. This is only KDHE.
So this is just all KDHE. All right. Thank you.
Yep.
Well, and I'm sorry. And then I might make note is on with your Medicaid, with our Medicaid being the 60-40 match, we're what, is it 75 on CHIP?
It is lightly higher, but I'm not sure exactly what it is.
So the match on CHIP is higher than
Right.
it is on Medicaid, yeah. Thank you.
All right, when you look at the funds that are going to that Medicaid assistance, that largest chunk of the funding, those funds are generally funneled through the managed care organizations because Kansas has a managed care system for KanCare. When KDHE receives their funding, those payments are made to the MCOs based on a per member per month. So the MCOs are paid by KDHE based on the number of people that are enrolled in Medicaid in each of the various eligibility categories. So some examples of the eligibility categories are poverty level eligible children, children receiving long-term care, pregnant women, and medically needy, aged, blind, and disabled. Now, the reason for this, for the various categories, are that some categories are going to generate expenditures that far exceed other categories. So children, poverty level eligible children, are generally going to generate far fewer expenses than a child that's receiving long-term care. And so to better estimate how much the MCOs will be spending on these populations, they're divided up into these eligibility groups, and then the amount that is paid to the MCOs is based on the number of people in those groups. Then, when you move from the payments from the MCOs to the providers, it's paid on a slightly different, in a different way. MCOs reimburse individual providers based on services in general. So these are, in general, physician services, hospital services. They're paid by the MCOs based on what they provide, the services they provide. There are a subset of providers, mainly CCBHCs and FQHCs, that are paid on a PPS system. This is a prospective payment system, which means that there's a single bundled rate that is created for each person that comes into those centers. So they're not paid by services provided, they're paid by people served.
Well, and I'm sorry, Megan. And then one of the things on that PPS rate is that that payment is once a day. So
Correct.
if for whatever reason you had two organizations in the same catchment area that had the PPS rate, if they show up at A in the morning and go to B at night, A gets paid, B does not get paid. Did you have a question? Representative Ballard.
Thank you, Madam Chair. I think you might have answered that because, okay, let me go make sure I understand. MCO pays providers for their services. But then after that, you lost me.
So the MCOs pay the providers based on the services. The providers will make claims. So if a doctor fixed a broken arm, they would make that claim to the MCO, and then the MCO would pay them based on what the service that they provided. The exception are CCBHCs and FQHCs, which are paid on this different prospective payment rate.
I'm sorry, that's the part I missed. Thank you very much. Thank you, Madam Chair.
Representative Senator Peck.
Thank you, Madam Chairman. I don't understand that each MCO develops its own provider reimbursement rates, but must reimburse at or above a minimum rate that is determined by the state. So we've got 3 MCOs. The same doctor, clinic, whatever, provider, having patients that receive services from different MCOs may be paid a different rate for the same service?
That's correct. So the MCOs are required to pay at the floor rate. So when the legislature sets rates or raises rates, what they're doing is raising that floor. They're raising the minimum rate. The MCOs have the option, so if they so choose, to pay over that rate, but they must pay that rate.
Are you aware, do the MCOs pay different rates, or are they all at the floor rate?
I don't know the answer to that. I mean, I would assume that there is a large variety because there are so many different rates that some might pay more than others in certain services, but I don't have that information in terms of the specifics.
It's like any insurance product. The insurance company goes out and negotiates with each provider a contractual rate. So the MCOs do the same thing, just like what Blue Cross or Aetna Commercial or any of the other insurance companies.
They have to play the base rate.
Okay,
Well,
Madam-
the MCOs have to pay the minimum base that we set, but it gives them the authority, should they choose to decide to negotiate a rate that's higher than that.
I understand that, Madam Chairman, particularly in the insurance, but it seems like to me if it's taxpayer dollars, which of course Medicaid is, that our providers should be paid the same no matter who is paying the bill. I'll try to figure this out, but it just doesn't make sense to me, and I've never been involved in this committee or Medicaid, but
Well, it's
I
different.
was unaware that our 3 MCOs could pay different rates for different services.
Well, because, it also depends upon, a lot of times in your insurance rates is the area of the state. It's no different than what Medicare does. There could be a Medicare product down in Wichita, Kansas, but you get up in Johnson County, they don't have the same products. You could have 10 different, I don't know how many different products there are in Kansas, but you can have multiples. But it just depends upon where you're at. And I think that the rates versus, say, an urban area versus a rural area are different. And so the MCOs, just like the commercial insurance companies, are going to negotiate accordingly.
I understand that, Madam Chair. I guess I was thinking if it's this different MCOs in the same location, I'll just use Montgomery County.
Right.
Different MCOs may pay a different rate for the exact same service to different providers or the same provider.
But there is.
Representing Concanon.
But the MCOs are receiving from the state the same amount. So it's not actually, it's their dollars, not taxpayer dollars, that there's a variation in. Does that make sense?
No, it's still taxpayer, because we're paying the MCOs. That's taxpayer
I-
dollars.
Right, but that's the same across the board. Where the variation comes is in what they're paying out.
Right.
I understand that, Madam Chairman. I appreciate that. But so some MCOs are more profitable than
I
others?
believe that we have a cap. And I think later on, we're going to hear from the MCOs today, so we can ask them, which would have more information than what Megan would have with it.
Thank you all.
You're welcome. Okay.
Hopefully here.
Oh, it's complicated, trust me. Representative Carpenter.
Thank you, Madam Chair. So to answer your question, the MCOs get paid on a per member per month. And then there's 38 capitation core categories of folks. So they get paid that no matter what they negotiate. But for instance, if they were, and they're tasked, when they sign up for that person, they're tasked with serving that person. So if they're in some place where there's a service that is not available, they have to pay higher to get someone to serve that person. And so they negotiate that, but it does come out of their profit. They only get paid that per member per month fee. So anything above that they spend, that's out of their profit at the end of the day. So we only pay X amount. And there is and Megan will probably talk about it, I use it all the time, the Medicaid report, and it explains, it's a very valuable tool, but it shows all the rate cells that we have, 38 of them, and what we pay for each cell, how many people are in that cell, and how much we pay per month for each person in that cell. That's what we pay. And after that, if they could pay less, they would make more too, but we have a rate. But if they pay more, and I've had a lot of deals where people couldn't get services, and so they negotiate with providers to provide that service. It's more expensive, but it's out of their pocket.
You also have in-network and out-network rates. Okay, Megan. I figure we'll just kind of deal with the questions as we go along, because I think it'll be easier for everyone, so.
Sure, absolutely. Another part of the rates, so as they're being created, the floor is set but they also need to be high enough that they maintain a provider network, that they're able to support a provider network, because the state is also required to have a certain number of providers that can provide each of the services required. So that's another reason you might see the fluctuation too. All right, my last slide, as Representative Carpenter went ahead and beat me to the punch, is about the Medicaid assistance reports.
He just likes to steal people's thunder.
I was
That's
trying to
what he
keep it
does.
suspenseful, but
No, Megan's got more thunder than you do, I'm just going to say.
so there is a copy of the most recent, well, the fiscal year 24 Medicaid medical assistance report in your testimony that you can peruse through. This is a publicly available document. It's on the KDHE website. It provides a really nice snapshot of how the funds are distributed. There are tables throughout it that show the capitation payment for each of those eligibility categories I talked about. You can see the number of beneficiaries in each of those categories. You can see the breakdown of the state versus the federal funding. So it's a really nice report. As always, you can reach out to any of the KLRD staff if you have questions about any of the funding or if you have questions about anything in the report. But I just wanted to provide it as a resource that I, and I know other legislators have found to be very helpful. And with that, I will turn it over to Dayton unless there are other questions for me.
We may find some, but we can always come back to you. Oh, wait a minute, Senator Fagg has a question.
Thank you, Madam Chairman. Thank you for your presentation. When I look at this, does the federal government set how much the administration part can be versus what we deal out? Or is every state a little different? I just wondered how we fit in that mix. Has anybody ever looked at that as a percentage? Because you said 5.8 for administration of Medicaid and assistance was 90. Just wonder how that number compared to other states.
We can compare that to other states because each of the states turn in a yearly report of their administration expenses and then their assistance expenditures. As far as the cap, I don't know, but I do know that as the agency creates new systems or updates systems, it must be approved by CMS, which is the federal oversight agency, and that they're being monitored for how much they're spending on these. And so while I don't know that there's a cap set, there's certainly oversight.
Madam Chair, follow up to that, please. Thank you. Do you have any performance-based budgeting forms that you guys fill out on different parts of this? You know what I'm talking about?
Yeah, there are, and I know that's one piece of the new contract, the MCO contracts, they all have performance measures that the agency tracks, and the agency can speak more to what those are and how they're changing, but the MCOs are expected to maintain certain levels of.
Does administration have a budget-based formula? That was kind of where I was trying to go with that, too. Do they ever set goals for what they need to do?
Healthcare finance does turn in performance-based budgeting items to us, to KLRD and the Division of Budget.
Yeah.
And I don't know specifically what their performance-based budgets or what their performance measures are off the top of my head, but yes.
Okay, thank you.
Are there further questions of Megan? All right, we're done until. Thank you. Welcome.
Good morning, Chairperson, members of the committee. My name is Dayton Lemunyan, Senior Fiscal Analyst, and I handle the KDAD's budget for legislative research. So thank you, Megan, for doing a lot of the heavy lifting, as she does as the KDAG analyst. I just have a couple slides on this first one. This is sort of contextualizing the overall Medicaid budget as part of the KDAD's budget. You can see that 89% of the total budget is Medicaid. So that would be, I'll give more detail on the next slide, but includes the waivers, nursing facilities, et cetera. And then you can see the next largest is behavioral health and aging and disability, which would be the non-Medicaid payments for those types of programs. And if we'll turn to the next slide, the Medicaid budget, the largest portion of it is for the HCBS waivers. The waivers are unique in that they're not inside of the caseloads process. So as you might remember from a previous presentation, caseloads are reassessed every fall and every spring by the caseloads group. And the waivers are excluded from that process because there could be a cap for any of the waivers. The next largest portion is the nursing facility payments, and then mental health services, which would include CCBHCs, then PRTFs, PACE, FMAP projects, and 1.5% of other Medicaid programs. And if you'll turn to the last slide. So there are a number of common adjustments that we see to the KDAD's budget. The first is, as Megan mentioned, increasing existing rates, and those would be ongoing. The second would be adding new services or new programs. So here I have an agency request to add the assistive technology service to the comprehensive waiver. I would note this was an agency request, so this is not actually in the budget. It's just an example of a type of ad that we might see. We also see adding waiver slots, which is similar to expanding a program, which the legislature did this year to add 500 slots. And finally, we see adding caseloads funding as part of that caseloads process. And that is what I have for the KDAD's budget. Happy to take any questions you might have.
All right, thank you. You know, for those of us that have worked with this stuff for a long time, we understand what caseloads mean. Can you kind of explain that a little bit? Because I want people to understand that we don't get to control how much is in caseloads necessarily, unless we were to cap, and I don't think we've ever put a cap on caseloads. We just accept them for what they are.
Sure. Thank you, Chairperson, for the question. So caseloads would be most of Megan's budget, the medical portion of KanCare. So if you're on a waiver, if you're in a nursing facility, then you would be eligible for that medical portion. So that's the bulk of caseloads, and those the funding, most of it comes out into a capitation rate that we pay to the MCOs, reassessing the population of the people that are eligible for those programs. Based on the rates, then we come out with the funding for caseloads. So as the rates are adjusted, as Megan mentioned, and as the population changes, we reassess that. And that's kind of the bird's eye overview of caseloads. Do you have more specific questions?
Well, no, and we reassess it every year when we also do our revenue estimates. I had a thought there. Representative Carpenter, go ahead, and I'll come back to my thought. I should have wrote it down.
So they're done twice a year, and the actuaries and the MCOs and KDHE negotiate these prices. Is that accurate, Dayton? What we pay?
So we have the new rates based on the actuarial, changes in rates. And then the Division of Budget, Legislative Research, and the agency come to a consensus on what the population is going to look like for the next month, for the next year and a half. Is there anything you want to add, Megan?
Is that all right? One thing I'll add is that what separates caseloads from the other Medicaid or KanCare expenditures is that caseloads encompasses those services that are required by the state. So Medicaid, as in order to get the federal payment, the state has to provide a certain minimum level of services, and that minimum level of services is what falls into the caseload expenditures. And those are set aside so that, because the state knows that these are expenditures that must be made for the program, whereas the waivers and the CHIP program, other things like that, while they're still part of KanCare, they're optional for the state.
Well, and I remember what it was I was going to add is on occasion, then the legislature chooses to add things to the caseloads, to roll things into the caseloads rather than to come back every year and try to figure out what that funding number is. So.
Right. Yeah, so things are added to caseloads, and as Dayton said, when rates are increased, those get rolled into caseloads. So the legislature does have the power to add things to it, But in general, it encompasses those services that are required.
Representative Ballard.
Let me follow up on that, though. If what we put initially in caseloads are basically mandatory, okay, so we have to do that. So when we add, are we taking anything we want? I thought we had to stay within the guidelines of what was mandatory, but maybe we had not included those things, and we're including them now.
There isn't anything that I'm aware of in statute that dictates what is and isn't in caseload. So there has been fluctuation over the years. In general, though, it is those that are the entitlement portion of Medicaid. Did that answer your question?
Kinda.
Well, and I think, Representative Ballard, some of the reasons that decision gets made, and Representative Carpenter, you can jump in on this, is that it's, when you have something you know that's going to be ongoing, it creates more stability. You also correct me if I'm, it will create more stability for that program if it's readjusted in the caseloads versus the legislature coming in and deciding whether it's going to be adjusted, stay the same, or whatever. So it creates some stability and consistency for the programs. And I think we've done that with some of our, when we realize we've got programs that are going to grow and have
Yes.
ongoing fluctuation, that it's better for them to be there. So would that be a good way to now? Yeah.
So in that, and it was on one of the earlier slides, is for instance, PACE. PACE is in caseloads because,
But
We
it
don't-
didn't used to be.
right, it didn't used to be, but we don't know what the utilization of PACE will be. We're trying to expand that program because it really is a money-saving program, keeping people out of nursing homes, keeping them in their home. So, but we had no idea at the time how many people were going to be accessing that. So rather than wait for the legislature and they say, oh, we're out of money, well, you put it in caseloads and it's adjusted twice a year. And so you can actually encourage people, you just don't say to them, we're out of money, you can't get on that program. So that's an example.
Yeah, because I don't recall us ever looking at caseloads and giving consideration to reducing them. But if it's an individual program, that's always a discussion, except maybe you, Representing Carpenter.
I was going to say, Madam Chair, there was a specific instance, and I think it was before both of these times, where as Chair of Social Services Budget, I was handed a $440 million increase in caseloads. And when you go to the legislative budget process, all I can say is it's a per member per month deal and a capitation rate. That's it. And I put a proviso in the budget that year that said that, and 6 states do that. I'm off track, but 6 states actually have legislative oversight of the budgeting process and the negotiations for caseloads. And I put and what happened was nobody would meet with me to tell me all the, so it died.
Okay, committee, are there further questions of staff? Oh, I'm sorry, Senator Petty.
I just wanted to clarify, because I think I already know the answer, but, so under the chart that was provided about the Medicaid budget breakdown, so the mental health piece there, that doesn't include the mental health funding like that we have with, that's comes through for the programs within our schools? Or does it?
Like the MHIT?
Yeah.
Yeah.
Well, so this is actually fiscal year '23 budget, so MHIT would not be included in this. In the future, it will be included.
Okay.
Not as part of the Medicaid budget, but if you're looking at the first chart that I have, it would be included in that behavioral health, the green portion, since it moved from the Department of Education to
Okay.
KDADS.
So starting next year, it'll
Yes.
be it will be included in this budget.
That's right.
And that was
thanks.
one of the other reasons to make that move, is to make that more visible on the funding sources. I'm going to get there. Senator Erickson.
Thank you, Madam Chair. Thank you, Dayton. Just a quick question. It's been a while since I've been in this committee. So Megan gave us numbers of total healthcare funding for this of 3.5 billion, and then I look at KDAD's and it's 2.2 billion. Is that 2.2 billion part of that 3.5, or is that in addition to the 3.5 billion that Megan presented?
Megan's portion was just the KDHE budget, so they would be in addition to
So we're
one
looking at
another.
about 5.7, 5.8 billion total.
All funds, yes.
All funds. And so can you, and it's approximately a six, I know that the S-chip gets a little bit different, but do you have the breakdown in dollars out of that? How much is federal and how much is state funded?
So for KDADs, if we're looking just at my final chart, the Medicaid budget by all funds, it would be about 40%, with the caveat that this was during the pandemic, so there was an enhanced FMAP rate as part of the public health emergency. So it would be about 800, 900 million for the state general fund portion.
Normally, the breakdown on when things are normal is about 60-40 for Kansas. There's some states that are higher on the federal side than we are.
I just have a follow-up to.
Oh, and Megan said the KDHE was 626 million.
Senator Petty.
This is just a follow-up. So with the AMHET, since it's now going to be in this budget, so kind of about the discussion that's going on so far, we're going to see an uptick here in the amount of funding. And it's not due to the fact that it's new funding, it's due to the fact that it's relocation of what we're already paying for.
Madam Chair, Senator Petty, yes. You'll see if you looked at the overall state budget, it would be a net zero because we'll have a deletion in Department of Education and an increase here in KDADs. I think there was additional funding added beyond what was in Department of Education to expand the program.
True.
So there's a small uptick. And yes, and there would be an increase in the KDAD's budget because of that change.
So just as a follow-up question, so when you talk to the Appropriations and Ways and Means, will you include that in your presentation?
So since it was included this year, I'm trying to think through our process of what our budget would look like. Yes, it will be included as I note, changes that were added in the prior year.
Thank you.
And the uptick, as you referred to, I think was $3 million, which was a governor's recommendation for the program. Well, but you had what was allocated in the previous year, and then in each year, the governor has actually, in her budget that she presents to the legislature, has provided an enhancement to that program each year, anywhere from about $2 to $3 million. And that's where we go in and add new school buildings to the program. All right, thank you. All right, I think what we'd like to do is definitely on the Medicaid report that was presented here. And I don't know, in order for us to track, because we use the spreadsheet to kind of keep consistent track, and maybe this becomes a spreadsheet item, just so it doesn't get lost, is I think that this committee should see this report. KanCare, this committee as it has evolved, in the beginning, there was so much that had to deal with the mechanisms, what's happening, services happening, and I think the budget kind of got lost in all of that, and that really hit home when the appropriations chair looked at myself in committee one day. He said, well, isn't that what you guys look at in oversight? Yeah, we don't look at the budget. So I think that's something that we should start doing going forward. And I think that this report and then something similar to what Dayton and Megan just presented to us. And then perhaps, between now and well, I guess we could maybe try to do something in, between now and October just to see what it would look like. But, what would be a good, report so we can see side-by-side comparisons as we watch that growth. Just like we do, Megan, in appropriations. when we're looking at that and we're saying, oh, well, we're up this. So then that raises questions for us, or we say, no, we understand why that hit. And just kind of a sample deal, it's just so we can kind of get a look at it and then say, okay, this is what for report form we'd like to see going forward. And then the committee can take a look at it and see if it makes sense to you or if you see changes or ideas. And I'm sure Representative Carpenter will or jump in on that, or even Representative Ballard, who's dealt with these budgets for a lot of years. So, good? So don't you think just putting it on the spreadsheet and having it explained there each time? Okay, thank you. All right, now we're going to go on to looking at KanCare doula services and rates, and we have up Yvonne Case, Medicaid Director of Operations, KDHE. Welcome to committee. Thank you, Dayton. Thank you, Megan.
Thank you, Representative Montgomery. I'm excited to be here to talk to you about doula. Like she said, my name is Yvonne Case. I'm the director, I like to say the director of operations for all things Medicaid, but I'm not sure I should say that today. Anyway, we're going to talk about our doula services and a fairly new program for us. As you know, and you can go to the first slide, we have a severe maternal morbidity rate in Kansas. It's steadily increased. In 2016, it was 56.1%. Currently 71% for 10,000 living populations, well, 71%. So a 6.4% increase annually, very concerning. Non-Hispanic Black women had a significantly higher rate than any other race or ethnicity. Compared to other deliveries, women who were enrolled in Medicaid or from low-income zip codes were more likely to experience severe maternal morbidity. I'm sorry, I do that every time I don't turn on the mic. It's because I'm naturally loud, I apologize. In that same time frame, there were 105 pregnancy-associated deaths trending upward during that same time frame to get us to that 71%, okay? So the non-clinical support of doula during the prenatal, pregnancy, birth, and postpartum process has shown to be an effective best practice, nationally recognized, that enhances the birthing experience, reduces complications, improves outcomes, and addresses the racial disparities. Now, in looking at the approach, we did quite a bit of research on the national level for a nationally proven approach. We worked with some of our stakeholders, gathered some information in the spring of 2023, particularly the Kansas Birth Justice Society, and we need to thank them for their work around this and some of the white paper documentation they provided. And then during that same time, one of our MCOs, United Healthcare, did a doula pilot in Kansas. So we had all of that evidentiary information as we pursued this project. There are 21 states currently that provide doula services under a Medicaid SPA. 43 are in some type, I'm on the second slide, yeah. 43 are in some type of process, right? Either they're evaluating it, have some other things there. So the doula rate in Kansas was set at $1,295 per delivery. Now, they don't deliver babies, but it's per delivery. We'll talk some more about that, okay? That's the capped rate. And it's aligned with doula coverage and other state Medicaid programs. A lot of research went into this. Initially, when looking at the doula rate, it was fairly close to the rate paid to certified nurse practitioners and to physicians, okay? Physicians deliver the babies and they get paid $1,751 or up to that, okay? That's their cap, so you can see the difference there. There was some rate differential between physicians and other provider types for the 9 OB global codes, and we're going to look at those in a minute, okay? So that's the Advanced Practice Registered Nurse and the Certified Nurse Midwife, those acronyms there, okay? So we took a look at all of that. Effective October 1st, the rate differential for same services provided by different levels of these practitioners, the Advanced Practice Registered Nurse and the Certified Nurse Midwives will be removed. All other codes will remain below the physician requirement. So there's no danger there. I know there was some concern there around that. All right, if you'll look on the next page, those are our OB global codes, all right? The doulas aren't billing for these, but the physicians are. And you'll see the differential in the rates there, okay, our current rates. So those are being increased, the new rate. And I'll just let you take a look at those. So I have an hour, but I'm not going to talk an hour. Hopefully you're not going to ask me an hour worth of questions. But I do have some concluding remarks. So I just want to say that we have a problem in Kansas, right? The severe maternal morbidity and the racial disparities that go along with that, okay? The solution that we've come up with is this doula program that's nationally proven, all right? It's stakeholder driven, and it's been piloted. I think those are exciting things where we're collecting data around this. The outcomes we expect to enhance member birth experience. We expect this to support the actual healthcare team, the licensed healthcare team, okay? Again, doulas are providing non-clinical services. We expect it to address racial disparities in maternal health and the outcomes, reduce birth complications, improve overall outcomes, and reduce maternal morbidity. There are 3 specific codes, just to reemphasize, that doulas who are non-clinical can bill for. Prenatal support, attendance at labor and delivery, and postpartum visits. They're not paid to do the services of a physician, but they are paid to support members who very much need it. So we're excited about this program. Thank you for your time, and I'll entertain questions.
All right, I think we'll go through the testament, all the conferees that we have on this, and then we'll take and come back for questions. All right?
Okay.
Next, I have Rochelle Colombo, Executive Director of Kansas Medical Society, and it's virtual. Welcome, Michelle. Are you there, Rochelle?
I'm here. Can you hear me or see me?
Yes, we can. Go ahead.
Thank you. Well, thank you, Madam Chair and members of the committee for allowing me to testify this morning, especially remotely. I have not done that, so I have newfound respect for all the conferees that have to do this all the time because it's much more enjoyable to be there in person with you. But I asked to be added to the agenda today because I think it's important for this committee to hear back from individuals who have been before the legislature working with KanCare and specifically with ways to encourage access to Medicaid and to maintain our network of providers. And as you all know, the Kansas Medical Society for the last several years has come before the legislature and asked for an increase in the reimbursement rate for the Medicaid physician fee schedule. It hadn't been updated since 2006 comprehensively, so for 18 years until 2023 when it was increased by 3% and then last year by 9%. And I bring this up because the legislature has been very intentional in looking again at what will retain the physician access to physicians for Medicaid patients, the reimbursement rates. The law doesn't require that the legislature specifically allocate what the reimbursement rate is. That falls within KDHE authority to change the physician fee schedule. But again, it hadn't been adjusted since 2006 comprehensively. And what we had happen over years was there were, in addition to cuts and of course the compound effect of inflation when the rates weren't increased, there were cuts. And then you had certain specialty groups come in throughout that time and say, you know, we need an adjustment because we're dealing with emergency care or pediatrics or certainly OBGYNs. All of those are a huge part of the Medicaid population, but they kind of piecemealed through. And so what you had happen was a very disparate, complex system that didn't acknowledge that all costs have increased and that reimbursement has generally stayed flat. And it became a question of how is this fair? And I think kind of fatigue in both the department and the legislature of every single year the squeaky wheel gets the grease, but we haven't had a comprehensive solution. And so the Medical Society was extremely pleased this last year when the legislature elected to appropriate the funds to implement the 9% across the board fee increase. And there was discussion between the House and Senate about whether that ought to be applied through a formula that had Medicare as the threshold. But ultimately, the legislature said, no, we want this to be simple, and we're going to do what the medical societies requested and do this across the board. We provide the numbers when we make a request like that to you. We go and we work with KDHE. They have all the codes. They know which codes have been increased, which codes have not. And so we get the data from them before we come and make that request to you. Unfortunately, we were not aware when we made that request that they did not include global codes. You heard those referenced a moment ago. Global codes can be utilized by a non-physician provider if they're doing a service that non-physicians can do. So labor and delivery includes some of those codes. Some of actually the most utilized codes in the Medicaid physician fee schedule are global codes. But we need to be clear, those are physician codes. The entire schedule is built off first the physician fee schedule. I think you heard that reference just a moment ago. But so when those were left out, all of the physicians that use those codes were left out. So that was something we were not made aware of, and we were very surprised by that. Next, just a few weeks after the legislature adjourned, and I believe before the special session, is when the notice was made that doulas were going to be added to the list of covered providers and services. And this was surprising to us because, again, the legislature has demonstrated an interest in being thoughtful and very intentional about making sure that Medicaid services are appropriate, that they're affordable, and that we are maintaining the adequate network of providers. And, there was, from my perspective, we had questions about if this was not previously a covered service, then where did those funds come from? And that was amplified when we learned just a few weeks ago that, in fact, the rate increase that was allocated and appropriated by the legislature was not applied as directed through the legislative process. And in fact, we received notice the last week of July that it would be applied through a multiplier of the Medicare threshold. And so some codes would get no increase at all. Some would get under a 9% increase, and few would get the 9% increase that was allocated by the legislature. And so while we understand that KDHE was trying to meet CMS guidelines so that we would not find ourselves rejected for the CMS waiver, none of that information was brought to the Medical Society in the last 2 years when we've been requesting increases. We didn't have that information as we were looking at what would be an appropriate way to take care of all physicians and therefore all sorts of Medicaid physician services. And it certainly didn't come up before the legislature in the conversations that would have allowed for that to be addressed. But it was a surprise to us because that's not what was passed. And now I think we're going to find ourselves with a physician community that's somewhat disenfranchised and surprised that this isn't going to be applied across the board, that some codes are going to get a double bump, some are going to get no bump, and some are going to get a fraction of a percent. And when you start looking at these codes and how far below the market they are, it really is disappointing. And so what I felt it was appropriate for this committee to be aware of that, to know that we want to be good partners with both KDHE and the legislature in having good data, bringing reasonable requests, and making sure that those have the intended impact that was desired by both the legislature and the KDHE and the Medical Society. We do intend to ask for another increase. In fact, our hope would be that the legislature and KDHE could work together to come up with regular increases or incremental increases on a regular interval that would help to address what we've been through the last 18 years, which we've gotten so far below that we aren't seeing physicians drop out of the Medicaid program, but they are limiting how many Medicaid patients they can add into their practice. And so you're seeing just a narrowing of access, not of the network, but of access. And not all physicians work for hospitals. Not all work in those top allocated codes, but almost every physician in Kansas is taking at least a portion of their practice is Medicaid patients. And so we really believe that if we want to maintain that folks have access to services, that we need to have a meaningful increase to the codes. We need to understand how they're going to apply before the money is allocated. And we need to understand how decisions to add in non-clinical services affect the access and reimbursement for clinical services, which is what the Medicaid physician fee schedule is all about. So I appreciate the opportunity to testify, especially remotely. I hope you've been able to hear me, and I will try to stay on for questions. And we'll just give the disclaimer that I'm moving my daughter into her college dorm room in Arizona today. So I'm on a bit of a timeline, but I want to be responsive and work with you all. And thank you again for this opportunity.
Thank you, Rochelle. We have a couple more conferees, and then we'll be opening up to questions. So next, I have Kimberly Swan, MD, Chair of the Kansas section of the American College of whatever. There we go, and Gynecology. And I don't know if it's her or if it's Dan Murray on behalf of it. Who do we have? Do we know? It's Dan.
I don't know if you can hear me, Madam Chair.
Yes, we can.
Okay.
Welcome.
Yes, good morning. And I'm in New Orleans, so you're lucky to even have me alive to testify.
Oh.
But Dr. Swan sincerely does extend her apologies for not being able to attend. As you all have probably become accustomed, and Rochelle knows this as well, it's difficult to wrangle physicians given their schedule and things that emerge, including giving birth to children or helping to deliver children. So some complications there for her. But we appreciate the opportunity to testify this morning. I think when we saw this item on the agenda, it was really a great opportunity to extend to you our concerns about the reimbursement rates for physicians as it relates to maternal codes. Certainly, I think many of the ACOG physicians were a little concerned, or at least surprised to see that doula services were added. Not that they're in opposition to that, or that they have any questions maybe about the outcomes that are related to providing doula services, but the number 1295 for that reimbursement code is essentially on par with what a physician is reimbursed for a VBAC, which is 1386.43. And so, generally speaking, as we relate, as it comes to the codes that relate to delivery of babies, vaginal births are reimbursed at a little over $1,500, cesareans at $1,684, and as I said, VBACs at $1,386. I guess I learned this morning that some of those rates must have been increased slightly to that 1,700 number that Mrs. Osterlund referenced. But every year, around 30% of births are Medicaid. So that's a large number of babies that are delivered by Medicaid, and we want to make sure that physicians are appropriately reimbursed for those difficult births. Again, I'm a little, I don't have the other numbers in front of me from the other states, but we're still woefully behind some other states, peer states that we have. Again, use this opportunity to bring this to your attention. I know that both KDHE and the legislature are concerned about this issue as it relates to maternal health and for delivery services. We had an opportunity, Secretary Stanek called stakeholders to provide some feedback. We appreciated that opportunity. I think they heard our concerns and already knew them, and they're implementing some things to address them, including a study to look at how we compare to peer states and implementing hopefully what Rochelle referenced in terms of an incremental and periodic increase on these rates. Again, appreciate the opportunity. I wish Dr. Swan were here. She's the expert, but would happy to stand for questions at the appropriate time.
All right. Thank you, Dan. And next we'll have Shannon, is it Flatch? And it's written only, Vice President of Healthcare Finance and Reimbursement, Kansas Hospital Association. So committee, at this time here, that's the end of our conferees on that. We'll open it up to question. I believe, oh, he stepped out. Questions? Senator Pett.
Thank you, Madam Chairman. For the Medical Society, when you were talking about the low reimbursement rates, were you talking about doula? Were you specifically referencing the doula, I guess is how you pronounce it, reimbursement rates, or all reimbursement rates from Medicaid?
That's for you, Rochelle.
Yeah, I got you. Sorry. Thanks, Senator Peck. Actually, I'm inserted in this doula conversation for two reasons. One, because we've been working on the Medicaid reimbursement rates for all physician codes. So the doulas are not, as I think you heard, I'm sorry, Yvonne referenced, that's a part of the global codes, or I think they were added under that. I'm still unclear on it, but the doulas have now been added to Medicaid reimbursed providers, and the legislature's been working on the fee schedule now for the last at least 2 years. So I was speaking specifically to the low reimbursement or the lack of an increase for the Medicaid physician fee schedule since 2006, and the fact that after the legislature adjourned, we learned that doulas were added to reimbursed providers. And I guess that where our surprise came from in that is, as you all know, who have been involved in this process, there's a lot of different ways to look at supporting the Medicaid community. A lot, from expanding access to adding in different provider types. But to the extent that those are medical services, we have to reimburse as the state through the state program, and the state allocates the funds for the reimbursement, and it hadn't been done in a long time. So that's a long answer to a short question, but I was speaking about the Medicaid physician fee schedule and the impact, and really asking you all and KDHE, what is the impact of adding in a non-clinical service, and where do those funds come from? The rate of the doula reimbursement is surprisingly high because it's not a clinical service, and you have low reimbursement for obstetrics and gynecology. So it seems at odds, and so it's really a question back to you all. Sorry if that's unclear.
So I probably should know the answer to this. If I've been told, I've forgotten. Do you have an approximate dollar amount or percentage amount between the reimbursement rate or the provider rate for an insurance versus Medicaid for the same service? Because my understanding is Medicaid reimbursement rate is significantly lower than what insurance pays, but I don't have any idea what the difference would be approximately.
That's a great question. So Medicaid pays less than half the commercial rate, and generally between 10 and 20% of the commercial rate. So incredibly low. It doesn't cover costs. I know that Dan could share some services some specific examples as that relates particularly to OBGYN care. We've got some specific numbers there. But it's about, like I said, 10 to 20% of commercial rate, and then it's still lower than Medicare. And you have to keep in mind, we were disappointed to learn that this was going to be set as a basis of Medicare, because Medicare is less than commercial, and Medicare is having cuts. And so when you're tying something to a threshold that's under commercial and is also being cut, you're not getting at the goal that you intended, and we want to do better with that. So I hope that answers the question.
Thank you, it does. Thank you, Madam Chairman.
And most of the times when we're looking at Medicaid rates, we compare them to percentages of Medicare is kind of how we operate with that, not so much the commercial side.
All right, well, thank you. I just was curious because
Right.
a lot of people that are on private insurance could lose their private insurance if we expand Medicaid. And so I thought, well, I would find out what the difference is between what private insurance pays and what Medicaid pays.
Right, you'd lose the 101 to the 38%.
Correct.
Would lose their insurance. And that includes being on Obamacare. Representative Carpenter.
Thank you, Madam Chair. So are we doing questions for Rochelle, or are we doing questions for anybody that's, okay, very good. Yvonne, could you come back up here? So on your doula service chart here, which one of these codes are actually reimbursed for doulas? All these codes on this?
None of those.
Okay.
None of those codes, Representative Carpenter. Those are the those are the codes. That shows the increase that physicians got with this legislation, so what they can bill for. And, Dan quoted something, but it's 1,821 now for that. I don't know what he called it. I'm sorry, I don't know the clinical term, but so there are only 3 codes for doulas, okay?
And I get that. It's misleading when it says at the top, just doula service. And then you've got all these codes here, and so 3 of them, which 3 are they?
They're not listed on here.
Oh,
I
they're
agree
not
that, I
listed
agree,
on here.
Representative Carpenter, that was just an oversight, I think, that it should say OB Global Codes at the top of this. So the doula codes, they're T codes, there are 3. So for the prenatal services, I believe it's $15 an hour. $15 for 15-minute increments when they attend prenatal and postpartum visits, okay? So $15 for 15 minutes. So if they're there an hour, $60. And for being present at birth and delivery, I believe, is it 500? 500. I'm phoning a friend, I'm sorry. That's our clinical team, $500 for that.
That would probably be a pretty good information to include in this slideshow.
I agree with you, sir.
Okay. So how much are we talking here?
The max, if they go to several prenatal and several postpartums at those $60 an hour, basically $15 for 15 minutes, and the labor and delivery, the max that a doula can bill is that $1,200, and it's on slide number 2, the $1,295.
Okay, but I'm talking about how much total are you figuring that budget will be?
Oh, I don't have that information readily available. I can get that.
Is it 2 million, 3 million? I mean, it would be nice to know what you're projecting for the increased cost.
Right.
For doulas.
Let us take that as a question and provide that back.
And a little bit through the budget process, this could have been something that the budget committees would have dealt with. Because you're looking at your budget, and I'm going, well, where did you get? I have no idea what it is, but if it's $3 million, I'm like, wow, where'd they get that $3 million? So it's just kind of weird that it's after the budget process and it wasn't properly vetted through the budget.
Okay, we'll take that back and provide that,
Yeah,
overall cost.
If you could get the committee that information about what you project the cost to be for this service, and also a sheet that just says.
The doula codes.
Yeah, the doula codes. Thank you very much.
Fair.
Thank you, Madam Chair.
Senator Fagg.
Thank you, Madam Chairman. Yvonne, since you're up there, I'll ask my first question to you. How do you market this program? I'd never heard of doula. How does people become aware of that?
So we've worked closely with some of our advocates and folks that are working with the communities where this is an area. It's a like I said, it's a national program, and the communities of color, if you will, know all about this. So a lot of times, I'm just going to give you a personal. When I had my first child, all right. I had a mama who held my hand, right, and told me all these things. Not everybody has that. And these folks are helping them, I think, make choices, informing them of questions to ask, helping with language barriers, all kinds of things. Support there that not everybody has, and particularly, it's going to impact these outcomes for children and women in our communities and keep them healthier. Does that answer your question, Senator?
Yes. The next question either goes to Dan or Rochelle.
Can I ask a question of her before?
Sure.
Well, let's stay with the same person, so we don't have them bouncing back and forth. So, Senator Erickson, is your question for Yvonne?
Yes.
Okay.
Thank you, Madam Chair, and thank you for being here. Just a couple of questions. So I kind of looked into the qualifications and kind of a little bit about doulas in the state of Kansas. So what qualifications does a doula have to have in Kansas?
I'd have to research that to know exactly.
Are you kidding me? Aren't you responsible for this program?
I'm a piece of the puzzle for this program. I'm your spokesman today. I have a clinical team member who can probably answer that question with me if we can bring her up to the podium.
That'd be fine.
All right. This is Shalay Harris.
Yeah, and if you'll announce at the mic who you are, so it's on our
Yes.
recording. Thank you.
Good morning, Shalay Harris. I'm the clinical director, almost, of the Medicaid Medical Bureau here at Kansas KanCare, and I can answer that question. The doulas have to prove to us training. They have two pathways of training pathways that they have to, forms that they have to send in to us. Those are attestation forms that they fill out that our vendor helps navigate those papers when they come in. They also have to show 30-some plus hours of training with a nationally recognized doula credentialing training courses. And then they did ask for an experience pathway for us to add. At this time, we were not comfortable to add that because we still have a lot of research to do around adding that pathway to become a doula in Kansas. One other side note is that because of the way it's under our state plan, CMS requires us for the doula to get a professional services recommendation. And so that can be from any licensed professional in the state of Kansas. We have that form available on our website. They also have it available in various offices that are in support of the doula as part of the care team. And then the member can also pull it from the website and ask for a professional to sign to receive doula services.
Thank you. And from that, I gather it's basically 30 hours of training through a national, that's 30 hours of training.
Yes.
Correct.
Yes.
What services specifically, they're non-medical, so what specific services, unique services do doulas provide?
Yvonne stated a piece of that. We have a lot of women in our disparate communities that do not have family support systems when they find themselves pregnant. And we know that they're scared, they don't have support. And so what they do is they find that doula in the community. In the state of Kansas, they have to get that professional to sign that recommendation. They find the doula, and the doula is to work with the care team, the physicians, to help with that support. They don't do any clinical invasive prenatal appointments. What they do is they talk through their nutrition, their health, how are they feeling, and then recommend that they see their physician when they need to. During labor and delivery, you can imagine for some women, it may be 6 hours. For some, it may be 48 hours, unfortunately. But the doula is there the entire time supporting, rubbing a back, maybe answering questions, and being that advocate in the room to work with the professionals to help them with those, to bring a delivery. We know because of that, during labor and delivery, C-section rates for doulas that are in those deliveries go down considerably. And then the postpartum, they help them with that. As you know, in the state of Kansas, we have a year of postpartum available to our Medicaid members, so they can follow them and be sure that they're getting home visiting, that they're getting their well checks with their physician, and that baby is getting into care as needed. Yes.
If I may, Madam Chair. So my daughter was an RN with the Sedgwick County Health Department. And
I've been there too.
Her entire job was providing prenatal services and pregnancy services to the very population we're dealing with. So I'm wondering if there aren't duplicate services available. And as an RN, she was able to provide that, not just support, but answering those questions. So I just wonder the overlap. But I guess my final question is, in researching this a little bit, are there doulas in Kansas that provide abortion support?
No. A doula, again, is is a non-clinical provider. They may be there for counseling if someone seeks them out for support after such a procedure, but they do not attend those that I know of. And for the duplicative services, Senator, that is, I think what you're talking about is a healthy babies program. That's in Kansas, the Healthy Start program, and that's federally funded. And those help with the touch points for the home visiting and immunizations and all those things that a family would need. So it's not really duplicative services so much.
Well, I looked up the Kansas Doula Network.
Yes.
Are you familiar with that?
Yes, they were our stakeholder group that helped us with this.
Interesting, because
policy.
they list on there very clearly abortion doulas.
I did not know that.
They do. And so I also look, and I know that it was specified that there are only 3 services that we're looking at through the state to
Yes.
provide, the prenatal and.
Yes.
But it also, I look on Sunflower MCO, and it says that they provide funding, it says on there, for community-based doulas. And I'm just wondering the specificity. It seems like there's a lot of unknowns here, Madam Chair, with the specifics of this. And so I would just like to vet this further going forward. Thank you.
Representative Ballard.
Thank you, Madam Chair. I am familiar with doulas. I haven't seen anything there, and I'd have to see that says that they provide abortion services. I've always, the little I do know about it is providing that network where people do not have people in order to help them. But I don't want to get into a debate about who provides what abortion services and who do not. I have just not seen it. And probably we should be referred to where that is stated so that we know that may be part of other things that some doulas do, okay? However, my question is directed for Rochelle. If she's
Yes.
still on. Okay. You mentioned something that that caught my attention, that because of the payments, that physicians would not be leaving the network, but they would limit the number of patients that they take on Medicaid. And that, I think, is one reason that it is important that we continue to increase those rates, because then that means that they would increase the number of Medicaid patients that they take, because even though they may be continuing, we know that there's other physicians out there that do not take Medicaid patients as well. So is there a limit? Does each doctor take just a specific number? Could you say they take limited numbers, but would there be more people, doctors leaving, if we do not continue on a regular basis increasing the rates?
Thank you, Representative Ballard. I appreciate that question. It's a great one. So the way you are correct, I mean, there are some physician practices that don't take any Medicaid. An example would be, you know, a concierge physician that doesn't take outside payers at all. But in general, like I said, most physicians, whether they're in specialty care or primary care, they set aside a portion. There are some that don't limit it at all. In fact, I've heard, this was something I presented, I think, back to the committee last year, Social Services Budget Committee, and though it's anecdotal, I think it's relevant, that I heard from a number of physicians who say, never have we ever, it's part of our model. There was a family practice in Wichita, there was a pediatric practice in Wichita. These are 2 examples specifically that said, when we started our practices, we decided we weren't going to limit Medicaid patients. We were going to take all comers, and that was going to be our model because we want to take care of our community. And that they did that, and that they hung on through really the transition, you know, so the last comprehensive update was in 2006. Then in 2010, you know, you began the transition into KanCare, which was, that was a lot for physicians. We believed in trying to do that because it makes good economic sense. But it was complicated for physicians to work with new payers and to go through that. And then under that, under the Brownback administration, there were cuts to the physician fee schedule. And so these two particular practices said, you know, we hung on through all of that. But the thing that really was discouraging was when the legislature looked at this, they looked at the rise of inflation, medical costs, all costs in the last 18 years, and KDHE and the legislature hadn't adjusted it. And physicians who were providing these services were not able to. I mean, they can't even cover the services. It's more expensive to provide the service and to go through Medicaid to seek reimbursement than it would be to just donate their care through uncompensated services. And particularly in Wichita, they have a wonderful program that provides a lot of uncompensated care, and that's just an easier way for them to do it. So those two practices said, we've never limited. Now we're going to begin limiting because it's clear that we're not going to be able to cover our costs. In general, you see most physician practices saying that the maximum that they can afford is somewhere between 10 and 20% of their population. I think that probably is decreasing, and I agree it's going to continue to decrease. The concern we would all love to see more providers, more physicians adding or expanding the number of patients that they would take. But I think right now we're in a position of wanting to maintain the network that we have. And we need to keep up this good work to do it. And they are encouraged, and they are very appreciative of the legislature's acknowledgement and an effort to do this. But of course, and I referred back to Dan a little bit ago, I think that the reimbursement rate for a well woman visit at a gynecologist is $17.50. So, and yet a Medicaid patient gets a $25 incentive payment to go and get a well woman visit. So a Medicaid patient receives more for going to the doctor than the doctor receives for providing that service. And while we're thrilled to see an increase, a 3% increase on $17.50 is not very much. And a 9% wouldn't have been very much either, but unfortunately, that wasn't even included because of the lack of global codes and the way it was applied to the Medicare threshold. So it's again, a long answer, but really, truly, Kansas physicians are very committed to caring for the Medicaid population. They want to do so, but they have to be able to at least cover their costs. And honestly, they're going to look for ways to provide uncompensated care if Medicaid doesn't increase steadily over time.
Thank you very much. I appreciate that explanation because I think it's extremely important that they get that reimbursement rate, but also that we at least, if not increase, maintain that they're taking them as well. Thank you. I would like to just comment on just a comment about people on, if you go to a Medicaid expansion, that they leave, that they lose their private insurance. That may be true, but I would imagine or assume that 41 states have been able to work that out, since it's only 9, and we're one of those 9 that do not have Medicaid expansion. But 41 states have figured out how to make this work so that they're able to keep some kind of insurance. And I mean, I just could not just let that go, because 41 versus 9 says that 41 states cannot totally be off base. Thank you, Madam Chair.
Representative Ballard, I might comment that the losing your insurance is a federal requirement of the Medicaid expansion under Obamacare. So it's not an option that states get to do. And it goes back, if you go back to the issue of as Obamacare started and everyone was told you get to keep your doctor, well, we found out that wasn't true. When you lose your current health insurance and you have to change to other health insurance, you do more than likely lose your physician. As we've heard previous testimony in this committee over the years, and I think we even may have heard some of it yesterday, is the shortage that we have of physicians that will take Medicaid. So there's almost a guarantee that you will indeed lose your physician. So it's that, I'm just giving you what the federal law is.
I realize the federal, but I will still say 41 states have worked it out.
But you still lost your physician. And we can argue that until the cows come home, and you and I can do that.
That's true, but we'll do it at another time.
Sounds good to me. Okay, let's see, who else we got? Senator Petty.
Thank you, Madam Chair. And I'll just make one comment here. We're talking about, I mean, there is what's called affordable healthcare options for those that want to go, that need to go that path. And Medicaid expansion would provide insurance for the working poor. So it's so important that we join in with the other 41 states. On the, this question is for Yvonne. Yvonne, I just wanted to make sure you had mentioned there were 3 codes, and you mentioned about the $15 for 15 minutes of service up to 60 minutes, the $500 present at birth, and then is the last one postpartum?
Yes, and it's also $15 for 15 minutes. And we'll add the slide as Representative Carpenter requested. We'll relabel the slide that's in there and add the other slide in a revised deck.
And following up on that, so I am hearing a lot in my area of the state, in the Kansas City area, a lot about doulas and the needs for their support. And so, are you? I'm assuming that one of the reasons that they're being included in the code is because you're set either through CMS or through your research that this is an expanding area across the country.
Yes, like we cited in our decks, there are 21 states currently with doula services as part of a Medicaid SPA, and there are 43 in total that are in the process. You know, they've done some kind of work in this area. So yes, it's the maternal morbidity rates that are driving this, and particularly with disparate groups.
And that's what I'm seeing in my community is with those groups. And actually, there have been issues on news programs in the last 2 months in the Kansas City metropolitan area concerning that. And they have to be registered with the state. Is that correct?
As a provider, yes.
To be a provider. Thank you. My other question is for Rochelle. And Rochelle, are you still there?
I'm here.
Are the number of physicians that are doing deliveries in the state of Kansas, is it continuing to decrease?
I don't believe so, but that would probably be better directed towards Dan or to Dr. Swan as the representatives of the College of Obstetrics and Gynecology. I will look into it, but I don't believe so.
Dan, are you still on?
I am, Senator. I don't have that information, and I guess as I go back and try to get to you that information, are you referring to the number of physicians delivering on Medicaid or generally speaking?
Let's just say both.
Okay, I will look into that.
Okay, I appreciate that. Thank you.
Representative Berquist.
Thank you, Madam Chair. Thank you, conferees, for sharing information with us for KanCare doula services specifically, and we're not as familiar with these services as maybe people that are more up to date. I'm wanting to be more up to date and understand it better. There's a code that's 59430 that's listed as postpartum care only, and it's a fairly small amount. Dollar amount is not an issue, but I'd just like to find out, does postpartum in the doula services available? Are those services available to post-abortive women also for those doula services, to counseling, the care afterwards, or is it just for after a live birth?
I had to phone a friend. It includes anyone that seeks care.
Anyone that seeks care that has been pregnant. Is that correct?
Yes.
Okay. All right. Very good. And also the statistic we heard earlier about the deaths of pregnant women. Do they include those that have died post-abortive?
I'm going to phone a friend again. Do you know?
I don't believe so. This is information that is from the maternal mortality
Can you
review.
repeat it for the mic?
Yes,
I'm
this
sorry.
is Shalay Harris again with KanCare. The stats that we put in the slides today were from the Kansas Maternal Mortality Review Board. And I would have to go look. We do have representation that attends those meetings, but I would have to go look and see all where those percentages came from.
I'd
Good
appreciate
question.
it if you do that. Thanks so much.
Okay, thank you.
Thank you, ma'am.
Representative Carpenter.
Thank you, Madam Chair. So, and thank you for this. It's turned into a little bit more than I thought. But so you did bring up some interesting points. How does this intersect with postpartum care?
The doula services
Right.
themselves, so they can attend postpartum visits with the mother at $15 for 15 minutes. So they can go into their appointments, they can counsel them about going to appointments. That's how it intersects.
But is that bucket doula or is it postpartum? Which bucket?
Well, okay, so let's say Shalay is my doula, for example. Okay, that's probably a bad example, but she's my doula. She can go to the appointment with me and bill for that, and then the physician is going to bill for the actual medical service or the clinical service that he or she's providing, or the nurse practitioner, whoever that physician-related service is, the clinical part. Does that make sense?
But I'm talking about more of
The doula?
Yeah.
So
So do they bill under postpartum? Or do
under
they-
their postpartum code, which is a T code, not listed here, I'm going to provide those to you, $15 an hour. I mean, $15 for 15 minutes, sorry.
And that would be charged to the postpartum bucket or the doula bucket?
The doula bucket.
Okay, so
Yeah.
then, but they could provide postpartum services too,
Not clinical services.
not clinical, but just,
They're not medical doctors. They're not nurse practitioners. They're not certified midwives.
okay.
I think,
Does that clear that up? You still look like,
I
looking at
think
me like,
Representative
maybe not.
Carpenter, where you're kind of going, I believe, is that you would actually have two billings on that appointment. You would have the doula billing, and then you would have the postpartum under Medicaid on that billing at the same time.
Yes.
And I guess one of the questions
Potential.
I got asked here was, does that mean the time that they're waiting in the office as well, or just when they're actually in the appointment?
It's for the time they request the service. Is that right, Shalay?
When they're in the appointment.
So if they
Oh.
go in at 3 o'clock and sit there for 30 minutes, are they billing?
No, I stated that incorrectly. It's the time they're actually in the appointment.
Okay, so sitting in the
They're
office
not.
doesn't count. Okay.
Right.
Was I on target, Representative Carpenter, with that?
Yeah, that's fine.
Yeah, that's where you were headed. Senator Fagg.
Thank you, Madam Chairman. This one is kind of towards Rochelle and also Dan, and you guys can decide which one here. Can you both hear this?
I can.
Dan, can you hear?
Yes, sir.
My question kind of goes to Medicaid bursts versus private pay bursts. And when you look around the state, I think, Dan, I heard you say 30%, if I heard that right. You can correct me if I'm wrong. But the thing that concerns me, I was in a hospital doing a tour one day, and the guy told me that there was like 80% Medicaid bursts in this hospital. And so we're looking at rural, I'm concerned with the idea of you're losing money on a Medicaid deal and you're in the rural area or maybe even inner city, I don't know, where if you're in the upscale urban area, that's where the doctors are going to make their money. And I'm wondering if in Kansas we could look at, or have they even discussed any programs to where we try to help with the coding in rural areas or areas that show that hospitals, have an 80% birth rate in that area. So I'm concerned why somebody want to be in rural Kansas, if this is correct, and be around a hospital that 80% of the births, you're losing money. So you guys might talk about that a little bit.
Well, I'll take a crack at it, and I don't have the number off the top of my head or the percentage, and so I don't want to be inaccurate, but I don't know the exact percentage, but I thought it was at least a third of the births in Kansas are Medicaid births at this time, and it may be more than that. And I will look for that exact percentage. It wasn't in my notes, and if Dan has it, I'll defer to him. The codes, to try to answer that, I think, the codes aren't regional. The code is just the code, and you can't control. Hospitals have to take all comers, and if those deliveries are, when a person comes in, they don't ask you if you're Medicaid before they check to see if you're dilated. They're going to deliver the babies and take care of them and do those things. And the other thing, this is just a bit of an aside, but I think an interesting aspect for you all to consider is that when you look at malpractice rates and risk of certain medical procedures, birth is among the highest for medical malpractice. I mean, it can be devastating both for mother and baby if there is an adverse outcome in a delivery. And so you have to consider, I think, as a part of this conversation, that physicians who are, there was a question earlier about the decrease in the number of physicians doing deliveries. It's the highest cost for malpractice coverage is if you're either a neurosurgeon or you're delivering babies. Those are the most expensive things to get malpractice coverage for. So you don't see as many family physicians delivering babies anymore, or general practitioners, which has kind of gone by the wayside because the cost of doing so just for your malpractice coverage is so high. And not everyone has to have, if you're not a physician and if you're not delivering babies, then you're not going to have that same rate. But if you're getting reimbursed a higher rate for non-clinical services that provide maybe emotional support for a delivering mother, you can see that would be very disenfranchising and not an encouragement for those physicians looking to maybe provide those services in either an urban or a rural area, because there's just a disparity there. So I'm confident I didn't answer your question, Senator Fagg, but I will work to get that number of Medicaid births, and maybe I'll punt to Dan for the second half.
Senator Dan Murray, in 2022, 31%, these are statewide numbers, 31% of births were Medicaid. In 21, that was 30%. In 2020, it was 31%. In 2019, it was 29%. And in 2018, it was 31% of Medicaid. So you can see that for at least from 22 back several years, that it's hovered around 30% annually. To your point, indeed, there are greater in different areas of the state, particularly in rural Kansas, there's greater percentages of Medicaid being used. I don't have those numbers regionally. I'm sure that the KDHE could probably collect that information. But yes, there's not only higher usages of Medicaid in rural Kansas, but also, as Rochelle pointed out, there's a lack of certain providers, including OBGYNs. The legislature did a couple of years ago pass a bill that would add OBGYNs to the Kansas Medical Student Loan Program. And that takes time to build that up, but hopefully we will get some OBGYNs in rural Kansas because of that program. So we appreciate that effort. But yeah, you will see in different areas of the state higher usage of Medicaid, and those rates would be different. But the 30% rate seems to be holding pretty steady for the last several years statewide.
Thank you.
Representative Reese.
Thank you, Madam Chair. I don't have a question, but I have a comment. If I just went on to the Kansas Department of Health and Environment, KDHE website, and you can see a section there called the doula kit. And it tells you what's required, what services are available, the billing, everything that we've pretty much been asking about is there under the doula kit. So any of us can look at that. And and become a little bit more familiar with what the doula services are about.
All right, committee, are there further questions?
Okay, because you can also go to ks.doulas with a s.org and find the services they provide, and that's where the abortion information came that Representative or Senator Erickson brought up. Okay, thank you very much. Appreciate your time. Arida or Elizabeth, either one, I believe that this probably needs to be put on our spreadsheet. And I think that, and jump in here, anyone else that has something that I miss on this list, is to be provided with all codes, no matter who's billing them or dealing with them, what each one of those codes pay, and then we would also want to see then what has been the total cost. Overlap, and this one might be a little bit tougher, but I think overlap of Medicaid services, as we heard earlier, so you can have a mother that goes in to see her physician on a postpartum issue, and so Medicaid postpartum would be billed as well as Medicaid doula would be billed. Then rates of the program and to whom that gets paid, because it appears as I sit and research through here that like you can find a Kansas doula directory, but it only lists one person. But then when you go into resources, you find doula communities, like Topeka may have one, Douglas had one, that type of stuff. Let's see, I'm missing something on here. Oh, and I think the other, other service programs that we have out there, because I know that the pregnancy resource program that we've had in place for the last 2 years for Kansas, we're in the second year of that, that provides services to women and their families through the pregnancy and then 2 years after the pregnancy. So well, I say 2 years after, it's up to the child becoming 2 years of age. So that would be a program that the state's paying for, programs that we have our local health department's paying for, anything that we can find along those lines. Committee, is there things that I forgot on here or that needs to be added that we can think of today? All right, if we do, we can just let staff know. All right, committee, thank you very much. Appreciate that. All right, we're actually ahead of schedule today. Oh, I didn't say that. I'm just going to jinx it. Go ahead. Smack me, Barbara. Smack me. There you go. All right, committee. Next we have on our agenda is KanCare 3.0, request for proposal formatting for scoring, prescriptive and non-prescriptive contract provisions, protest update, and update on managed care organizations with signed contracts for 2025. And the first, and I don't know how this is going to be done because we have representatives with KDHE, and it looks like that we have 3 different. Okay, we have counsel from the Department of Administration, counsel from KDHE, and counsel for KDAD. So which one of you is going to start off for us? Who's taking the lead? All right, you're willing to step into the hot seat. Come on down. Welcome to committee. Make sure you tell us who you are so we got it on records.
Thank you. Good morning. My name is Pat Doran, Chief Counsel for the Kansas Department of Administration. I'm appearing along with Sherry Deal, Chief Counsel for the Kansas Department of Aging and Disability Services, and Brian Vasquez, General Counsel for the Kansas Department of Health and Environment. As the committee knows, 2 ongoing civil suits are being litigated between the 3 agencies and Aetna Better Health of Kansas. One involves CORA issues. The second involves Aetna's request for judicial review of Director Todd Herman's decision to deny Aetna's bid protest for the KanCare 3.0 awards. There's also a third matter in contention between the 3 agencies, specifically Aetna's contractual performance under KanCare 2.0 involving transition activities. Recently, the agencies in Aetna were involved in a court hearing on Friday, August 23, in Shawnee County District Court, where a variety of issues were argued. The Shawnee County Court has not yet issued a decision. With these matters in contention between the three agencies in Aetna, the legal counsels to the respective secretaries advised that they, versus the secretaries, should testify before the Bethell Committee on matters involving KanCare 3.0 and Aetna. Sherry, Brian, and I are happy to address any factual questions you may have, but respectfully inform the committee that we will not answer questions that cross over into legal argument or analysis, since it could impact the ongoing litigation. Thank you. Happy to stand for questions.
Committee, are there questions at this time? All right, we'll see where we end up with. Thank you. All right, next I have Jane Brown, Plan President, Aetna Better Health of Kansas. Welcome to committee, Jane. I don't think it's on.
Oh, can you guys hear me now? Great. Well, thank you for inviting me back today. I also want to have a factual discussion in terms of where we stand today. And I'm not here to make any sort of legal analysis or anything to that effect. I think all of those proceedings continue in front of that judge. What I'd like to do, however, is start this conversation with where we left off the last time that I was here, which was, where are some of the documents that Aetna had requested in order to better understand the grading that had occurred relative to our performance and our bid results? You know, since the last time we've met, we have found out that all of those documents were very deliberately deleted from the record, and there's absolutely no way for us to be able to access them again and to review them and really get a sense for why a tiebreaker was decided within a space of several hours without any sort of an objective criteria. What worries me as I look through the record is that even when the consensus scores were developed, you know, there was very clear feedback from the Department of Administration stating that the way that the consensus scores were coming together, it was not considered to be sort of a justifiable reason or reasoning as to why somebody got a good score versus somebody got a bad score. I provided a lot of testimony, and one of the things I'd like to draw your eye to is in the timeline document where we talked about, you know, on March 19th, the responses the evaluators gave are not congruent with what would be a legitimate review. What troubles me about that statement is that this feedback was shared 12 days after all of the underlying scoring documents had already been eliminated. So now you have a situation where you have to create consensus scores with no supporting real information from the actual subject matter experts who had spent months going through the RFP proposals themselves and developing sort of context and grades. So now knowing that those scores, you know, are completely gone, you know, from our perspective or from my perspective, it's just a huge problem because when we look at how this tiebreaker was decided and the information I provided to you in terms of timeline, it really shows that there's just really no objective criteria that was set out. A handful of emails between the PNC members and the night before being told that they can't even use any of the oral presentations that we had done as part of this negotiated process. I'm getting the strong sense, and this is now my personal opinion, but I'm getting the strong sense that the scores don't matter. I keep hearing that this was a negotiated procurement. Well, it would have been nice to know that we were having a negotiation after those initial scores at the time that we were having trials. So I really I implore this committee to use its discretion and its power to provide some oversight. And my hope that the next procurement, that is, you know, one of the biggest and most important procurements in history of Kansas, right, in terms of the amount of dollars that are being awarded, I hope that there are some rules that are developed, some transparency and some fairness that is reintroduced into this process. I continue on almost a daily basis to hear from members and providers their disappointment, outrage, and sheer disbelief that this is what is happening in our state. So I will pause, and I'm happy to answer any of your questions. I know I submitted quite a lot of information to you, but I really wanted to walk out of this room today knowing that I had shared with you everything that I was seeing so that you could understand my outrage and disappointment in this process.
All right, thank you, Jane. All right, committee will take questions at this time. Those are the two presenters that we have. Representative Berquist.
Yes, thank you, Jane, for your testimony. We understand, or I guess we believe we understand that although the records of the tabulated scores have been destroyed, we are of an understanding that maybe the cumulative scores are still available. Are those available for us to audit?
Yes, so there are cumulative scores that are available. This is what they're referring to as the consensus scores. I think the problem that we have with the consensus scores is that they're unreliable. I mean, I looked at one specific question because I wanted to understand why we scored very low in this particular question. And there were a number of weaknesses that were attributed to Aetna. And some of them were in direct quotes, like Aetna said, direct quote, XYZ. When I actually looked at our response for that question, literally those terms were not once utilized in that answer. So there are weaknesses that are being attributed to us as part of the weaknesses that aren't actually ours. And we are unable to audit the underlying sort of documents and evaluation elements that were provided by the subject matter experts to understand where some of those comments came from and why they were attributed to us. I think when you think about a consensus process, basically what's happening is you have a group of people who get together and they have a conversation. And when those conversations are happening, you are relying on very much on the note taker, in this case Mercer, that they captured everything correctly. And when you're talking about 7 different MCOs, that you attributed the correct items to the correct MCO. And when you start getting into this very sort of almost subjective approach to how it's being done, or I guess non-prescriptive approach, it could be fraught with error. I mean, usually if you have, for example, a vote of some kind, you should be able to go back and count the ballots. You should be able to do an audit. You should be able to verify or validate in some way or fashion that the final count is accurate. Unfortunately, we can't do that. We can't even go back to find out whether we really did get 522 or whatever the final number was, or if there was something else. I always thought that it was the odds of 2 MCOs getting 522 exactly on the nose out of 36 questions across the sort of many grading opportunities of 0 through 5 or 1 through 5 was very odd. Like, how is it possible? Like, what are the odds? If I was a betting person, which I'm not, I would never have bet that 2 MCOs could nail exactly the same exact score out of 1,000 possible points in 36 questions. So it feels like this whole consensus process was very subjective, and we really don't have a good line of sight to how it all came together in the end. We do know that when the secretaries, and Secretary Stanek in particular, first received the consensus scores, she asked 14 questions. In her email, she never once said, oh gosh, we have a tie. No, she said, I have these 14 questions. And at least 4 of those questions were all about a particular MCO not having done very well in the responses. And I thought that was so interesting because in the end, when you actually looked at the consensus scores, it clearly showed that that particular MCO did just fine in those areas. So I guess I'd love to know what really transpired behind the scenes, because right now this is as murky as can be. This is a complete black box in terms of how this really occurred.
Thank you, Madam Chair. I believe she answered the questions I haven't asked yet, so as well. And thank you, ma'am, for your testimony.
Thank you, sir.
Committee, further questions? Representative Carpenter.
Thank you, Madam Chair. I think I want to start my comments out by the fact that in this process, it does not matter to me who the MCO is. This is not about Healthy Blue. This is not about Aetna. This is about a fair process. And that is what disturbs me, and rightly so. You've said that this is one of the biggest financial deals that this state will ever enter into. And to have it marred with, I'm not even sure what word I should use.
Scandal.
Well, that's not the word that but I
personal
do think
opinion.
that it does mar the process of transparency of selection of these folks, whether it's Aetna, Healthy Blue, I don't care.
Right.
I just think that this whole thing, I just can't get past the fact. And so, Madam Chair, I have questions for the Department of Administration. So,
Being we've only got 2 conferees, and you'll have you guys kind of doing jumping jacks up and back and forth, which we don't normally do, but that'd be fine.
thank you again for being here. So my questions revolve around the destruction of the sheets, or whatever you want to call them. I'm not sure what the technical term is for that. What do you call that technically?
They were individual evaluation notes.
Okay. So my questions revolve around that. Is that common practice for any procurement or any contract or anything like that that you've entered into, that those procurement notes or whatever you called them are destroyed?
This was the process set up for this particular RFP. Each one may be different depending upon how the agency wants to approach it. I am not familiar with other RFPs that included this step.
So there hasn't been another step, is that what you're saying, that where the documents were destroyed?
Another RFP.
Another RFP where the documents, what'd you call them? Evaluation documents.
Individual evaluator notes.
I've heard it called about a half a dozen things, but anyway, so you're not aware of any other procurement or anything like that where those documents were destroyed?
Again, I'm not aware of another RFP that followed this particular process.
Okay.
This was a process that was established with the assistance of Mercer.
And can you elaborate on what would
Hey,
cause that?
Good morning.
Good morning.
Can you elaborate on why that would be part of the process to destroy those?
I cannot.
You know, in government, we have, you know, we're terrible about saving documents. You know, I would imagine we have warehouses full of documents, you know, preserving those for a period of 3 years. I mean, there's statutes that require us to save them for 3 years or 7 years or whatever. But I'm not aware of anything that would, how we would destroy a document that potentially would have use in settling this case. Are you?
I'm not aware that these documents would have use in settling this case.
Say that again?
I am not aware that these documents would have use in settling this case.
And why would you say that?
Because it was a consensus evaluation process, and the notes were simply how the individuals collected their thoughts leading into the consensus evaluation.
So you think that has no bearing to go back and look at?
I do not.
That's all for now, Madam Chair. Thank you. Thank you for your answers.
Of course.
Senator Baumgardner online.
Thank you, Madam Chair. Can you hear me?
Yes, ma'am.
Okay.
Who's your question for, I guess?
Again, it would be for KDHE.
Okay. We have the Department of Administration kind of heading up with 2 others, so it's however you want to do it.
Department of Administration, no, Kate, whoever just was up there speaking about the process.
Madam Chair, members of the committee, my name is Brian Vasquez. I'm General Counsel for the Kansas Department of Health and Environment. And as Pat already mentioned, you have basically the 3 chief counsels from 3 different agencies here. Let me start with what this procurement was. procurements of this size are run through the Department
Am
of
I asking a
Administration.
question?
And I would like to have a repeater question, but
I haven't asked a question yet.
okay. But this does involve Medicaid and a managed care program, KanCare 3.0, and I'll be glad to try to answer the question, and if I can't, I'm sure Pat can.
Great. So this is the third time that we've been through the bidding process. And explain to us how the process changed from KanCare 1.0 to KanCare 2.0 to this. Are we to understand that the documents were destroyed in the process for the first KanCare vetting?
I do not know about 1.0, but my understanding is that the individual evaluation notes in KanCare 2.0 were also destroyed. I was involved in that litigation, and to be fair, that issue did not get raised in front of Judge Tice in 2018.
Was it raised at any point prior to the litigation of 2.0?
I am not aware at that time. AmeriHealth and AmeriGroup were the ones challenging the bid award, and I don't remember either one of them raising the issue about the individual evaluation notes.
I guess knowing that that went to litigation, is there a particular reason? Was it the recommendation of the consultant Mercer destroy the documents? It's just curious to me knowing that 2.0 went into litigation. We wouldn't retain everything to make sure, learn from an experience and make sure that all documentation would be available to verify and to justify should there be litigation.
And I wish I could answer that, but I can't. It was just not raised in 2018. A somewhat similar process occurred where the individuals, and they were all employees of the state with experience in managed care and a variety of aspects, reviewed all of the applications from the 7 bidders. There were 36 questions. There were 4 teams. Questions were assigned to each team. They reviewed the responses that were provided by the various bidders. And as Pat said, these were their notes. They were then invited in 3.0 under the guidance of Mercer, our contractor, to discuss their notes and their conclusions and then prepare a consensus review. Consensus meaning that the entire team had to agree to not only what was the rating on the question, and the rating went from a 5, which meant that you knocked it out of the park, you answered it 100%, to a 1, which meant you got no points. Each question had points. Then they went on and wrote pros and cons about each bid. But it was that consensus review document that was what was then prepared and then shared with the procurement negotiating committee. Yes, those individual evaluation notes were then accumulated by KDHE at the request of Mercer the first part of March, and those were destroyed.
So, Madam Chair, obviously, we have multiple attorneys there. Were the attorneys consulted as whether or not the documents should be destroyed?
I can't speak for the other 2, but I know I was not asked that question.
Madam Chair, I will simply say, there's been a lot of coverage about the serious concerns of how Spark funds have been distributed that have come to light just recently. Lack of vetting, lack of transparency, having the right or perhaps not the right people in making those decisions. It is very concerning to me that, every step of the way, knowing that since we were moving into 3.0, there would be a whole lot of focus, a whole lot of attention. It does seem disingenuous that documents were destroyed without consultation of an attorney, particularly knowing that 2.0 had gone into litigation. It seemed reckless, careless, and I appreciate the opportunity to ask questions. Thank you, Madam Chair.
Senator Peck.
Thank you, Madam Chairman. Some of the questions I had have been asked and semi-answered, asked by Representative Carpenter and Senator Baumgardner. But following along these lines, it's amazing to me that knowing 2.0 faced litigation, that probably 3.0 would as well, that anything was destroyed, because we are told as legislators that text messages, emails, any documentation we have, written documentation, can be subpoenaed. So my question for the gentleman, either one, would be, is it only the individual evaluation notes that were destroyed? It was mentioned there was a consensus revenue document. How much destruction of, I'm going to use the word evidence, occurred by the agencies or the individuals involved?
Okay. If I could, it's Brian Vasquez again. My understanding that the only destruction involved those individual evaluation notes, the consensus forms that showed the rating and then the pros and cons statements were then prepared in that team, and then that was what was provided. And quite frankly, we have a 17,000-page record down at Shawnee County right now that includes all of those. And so to a certain extent, the court is also looking at it. But those individual evaluation notes are the only ones that I am aware of that were disposed of through the process.
All right. And so then I would have a question then for Ms. Brown.
May I follow up?
Sure. From my perspective, it's fine if the chair allows. I'm sure she will. She's busy. Go ahead.
Pat Dorn with the Department of Administration. I concur with Brian's statement that I'm not aware of another step in the process that involved the disposal of documents. But I would have to speculate on things like individual notes that people took throughout the process. I mean, it's possible that what they wrote down on a sheet of paper they put into the disposal bin. I do that on a daily basis when I'm done needing to refresh my memory of things that I have written down on my personal notes. So I can speculate that it may have happened, but I don't know.
All right. Thank you. My question for Ms. Brown would be, and I know that you did not know ahead of time that you would be involved in some litigation. You didn't know if you would or would not be selected to continue as a KanCare provider. So I think I probably know the answer. But had there been, to your knowledge, any request that the individual evaluation notes or any and all forms, notes, documents be retained in the event that there may be litigation? Do you know if there was any request from you or Aetna or any other bidder?
I don't, I don't think we went into the process even considering that anything that could constitute a public record would be destroyed. So I don't think we, made a request up front to, not to request that they don't destroy anything. I think the statute on the books in Kansas already protects public records, whether they're notes, guides, scorecards, you can call them what you want. Even handwritten documents are still a part of that record. So, I don't think from a Aetna perspective or a managed care perspective, I would, think it'd be even necessary to request that a state maintain appropriate record keeping through a procurement process. I would just think that would be the default of the process.
Thank you. I would tend to agree with that answer. I'm a little bit, no, I'm a lot shocked. I was going to say I'm a little bit shocked. I'm a lot shocked because of what we have been told as legislators to make certain that we either do not put anything in writing, or if we do, that we maintain a record. Madam Chair, that's all I have for now. Thank you.
Can I also just add one more thing in terms of, I don't know, I cannot answer if anything else was destroyed, but I can answer what we have requested through the litigation process as part of the, I guess, evidentiary discovery process under KORA. And we have asked for, versions of the consensus documents. We'd like to see how that consensus document evolved. And clearly it did evolve because there's feedback from the Department of Administration, several weeks after you already have this big deletion of guides. You have this communication saying that this consensus isn't justifiable. Like, these don't make any sense. You can't legitimately, understand why somebody is a 5 and somebody is a 1. And so they were asked to go back and essentially beef up the consensus. So in that process, would there not be a version 1, a version 2, a version 3, a version 4? How many versions were there? I don't know the answer to that. I only ever got one final version, but I know we wanted all the versions. Sorry.
Senator Petty.
Thank you, Madam Chair. And this is a question for, and thanks, Jane. This is a question, I think it's Pat. Sure remember Pat? My name's Pat. I just wanted to be clear. When the RFP was put out, what within the RFP did it specify how the evaluation would go about?
The RFP listed all of the 36 technical questions that each bidder was required to address. It indicated the score that would be assigned to each of those questions, so the bidders would know that one may be more valuable than another.
And, okay, so it specified that the bidders are the MCOs, potential MCOs that were, the companies that were bidding to be one of our MCOs, that they would, when they saw the results, they would be seeing a score in the areas that were being, in the 36 areas that were being evaluated?
There would be a score as part of the technical evaluation process. There was 3 steps to the evaluation process. There was a mandatory evaluation of compliance with all of the requirements of the RFP. There was a technical evaluation process that involved this consensus review and scoring, and then there was a cost proposal process. All 3 of those were part of the negotiated procurement process.
And so I think you mentioned, or was mentioned earlier, that the individual notes were the only things that have been destroyed.
To my knowledge, yes.
To your knowledge. And so what's available to those organizations that had been part of the, had responded to the RFP is that final evaluation score in each of those 36 areas, along with what?
So there was a website established at the Office of Procurement and Contracting that contains the record for the RFP. There is an Excel spreadsheet that was posted on that website that showed the question for each bidder and the score that they received for that question.
Thank you. It does seem to me that, I mean, I'm worried that it just seems that if these individual notes that are being continually brought up, that then would then be, and you said there were 14 people that were on each one of these evaluations, is that
There was
correct?
4 evaluation teams. Each one had 5 individuals, so a total of 20 people, 5 on each team.
So 4 teams, 5 on each team, and did each one of the teams evaluate each one of the applications?
They evaluated the questions that were assigned to that team. Not every question was addressed by every team. It was the team's questions were based on topical areas.
And just as a follow-up, when in 2.0, and when this went to litigation, that this issue about the individual notes and the fact that they were destroyed at that time never was an issue.
Correct.
Thank you.
All right, and I'm going to go to Representative Concanon because she has something that tags along with apparently what Senator Petty was discussing.
Thank you, Madam Chair. My question's for Jane. Start with anyway. So let's go back to, you said that in your Cora request that all you got was a final version.
That's right.
I'm trying to follow all of this. Did you request every version?
Yes, and in fact, let me confirm, did we request we did request every version.
So what's happened to the other versions? Were they destroyed?
I don't know, they were not provided.
Okay, thank you. Then, is it Pat? Yeah. Thanks, Jane. So have those other versions been destroyed?
Each of the departments involved in the KanCare 3.0 RFP process, in addition to the governor's office, received Cora requests for documents related to the RFP. Anything in possession of those 3 areas have been provided to Aetna or any other bidder who requested it.
Okay. Okay. So they requested every version of it. There were multiple versions.
If we possessed multiple versions, they were provided.
Okay. I mean, they believe that there are versions that they did not receive.
I heard that.
Okay. All right. I'm trying to follow it all. Thank you.
Well, and if you have other questions, we can always take and come back. So then I have Senator Fagg.
Thank you, Madam Chairman. I've got one for you and then one for Jane. I just want to confirm, did you say that RFPs, you're not aware of any of them that's ever destroyed documents? Did I hear that right? Can you go over that again?
I'm not aware of other RFPs that had a process that listed there would be the disposal of documents as part of the process.
Okay. All right. Thank you. And then I've got one for the Madam President for 2.
Good afternoon.
Madam President, I was wondering, Aetna, how many states are they in?
Well, between our lines of business, we're in every state, but for Medicaid, we're in 16 different states.
Okay. Are you aware of any other time that documents were destroyed in any of those?
Well, I can't go back through all of the history of Aetna of several hundred years and all the 30-plus years of managed care across this country, but I can tell you that last week in Arizona, a similar situation came up. And in that case, the judge ruled in the favor of Aetna because in that case, their state entity had destroyed all of the individual scoring documents. And so they could not go back and validate or audit that the process had gone correctly and that things were added up correctly. So I guess I can tell you that in the most recent example of this in this country, which was last week, Arizona sort of said, you guys have to redo this. and do it right.
Representative Ballard.
Thank you, Madam Chair. My first question would be Ms. Brown. All right.
I like Madam President. That was good.
Well, you know, having just come from Chicago last week, I understand, okay?
What were you in Chicago for, Representative? Don't go there.
I'm not going to go there, but since it came up, though. All right. This is a very difficult situation. What I'm trying to figure out is, it's the individual evaluation notes that were destroyed. Am I correct? All right, so then I need Mr. Vasquez to stand next to her, because it's going to be like that, okay? So only the individual notes, right?
Please.
Just to,
Join.
Yes. Yes, that's my understanding.
all right, so normally in individual notes, when people make an evaluation, they have to sign, okay? So if you have 4 teams and 5 people were on each team, if I'm following you correct, right?
The way it's been explained to me, there was no signature involved. This would be like notes you would take while you were reviewing a textbook. You wrote your notes. If one of the areas was called case scenarios that had the most points, and there were scenarios where a person who is heavily disabled was needing services, and they went on and provided details. Each MCO was then required to respond to that and say, how would you help that person? And then that particular team would look at that response, and this was the written response provided at the first, roughly January 4th on 2024, and they would say, that's a good response, that's not, no, they're forgetting about, you know, non-emergency medical transportation needs here. They would go through and say, that is a 5, you get 100% of the points, or a 1, or a 4, 3, 2, somewhere in there, and then they'd write notes and say it. They would then take their notes to the consensus meeting, and they'd sit around and discuss. And those of you who have been in maybe study sessions with others where, you know, what do you think of what the professor said? One will say, well, I think he's absolutely right. Another person would say, no, he's not. And they would discuss it. But before Mercer would allow them to complete their process, all of the team members had to agree to not only on the rating, but on the pros and cons. That's the consensus review document that got prepared. Okay. So to a certain extent, if there were different versions, it might be as they went through the process to get to that consensus. But that's what was preserved. Looking back on KanCare 2.0, and it goes to the senator's question over here maybe, the one difference might be between 2.0 and 3.0 is we did not assign points in 2.0, but there was still this evaluation process. And to be fair, that's where the tie occurred at the technical review between Aetna and Healthy Blue. They each ended up with 522 points out of the technical review, and that's when they went on into the rest of the process to look at the cost proposals to see if they're actuarially sound rates, and that's when they also had the face-to-face meetings with the procurement negotiating committee. And yes, there were 14 extra questions that Secretary Stanek, Secretary Howard, and I believe it was Bonnie Edwards at the time from Department of Administration prepared that they asked the various MCOs to respond to during their roughly 2-hour presentation.
Okay, so now you've answered my second question. Oh. Because if, number one, no, that was great, because I wanted to know about the signatures. I have served on several committees at the university and just organizations as well. But what I'm thinking is the ones where we've had to sign and everything else, many of those have been destroyed because there were signatures that could be identified to the person making the comment, okay? And that's why I wanted to know, were they, because it's almost like a confidential thing you're doing, so therefore, if your name is associated with it, you don't want that, you know, to be earmarked at that time. But you said, in this case, there were no signatures on these. So that would kind of raise the question, why did they have to be destroyed? Because there was, there was no one to be identified. So that was part of it. But then you answered the other question, how did you arrive at the 522 tie? And this is where it occurred, if I hear you correct, right? Okay. Then who authorized that to be destroyed?
I wish I had a clear-cut answer for you, but I do believe it was the protocol that was developed by Mercer, the contractor for use in this particular RFP. I'm pushing the envelope of making almost a legal conclusion, and I really, as Pat laid down the ground rules, I'm getting close to that. But I think there is some evidence to indicate that that was where that decision came from.
Okay. Thank you for your questions. In the case you just talked about in Arizona,
Yes, ma'am.
what was your main objective in that case?
I'm not as close to it to go into the details of what happened, sorry.
Okay.
I just thought the decision was interesting.
Okay. I think I'm fine with the questions. Thank you very much. Madam Chair, I have a little of a big concern in this case of the transparency. And I can understand how things can be destroyed because of individuals involved in it. But with the transparency, if I receive a grant, which I have many times at the university, I am required, and I signed that I will maintain all of the notes and every payment I make and everything for 3 years. I have always, they give you a time limit that you must keep it in case you have to review it and everything else. So if there weren't any signatures involved, maybe this was a totally individual case. It could be straight up and there wasn't anything implied other than just making this decision. But on a 5-22 tie, or any kind of controversy, if we've ever been hiring someone or interviewing each other, or even for scholarships or awards that we give, if it's anything close, we keep everything just to say there was transparency. And that is to protect the people doing it and everything else. Transparency is an issue for me in this. You've answered all the questions I had, and yet I feel very uneasy about the process. Thank you, Madam Chair.
Senator Erickson.
Thank you, Madam Chair, and thank you, Representative Ballard, for that great segue. As I sit here, I want to make it clear, as a previous committee member made, this isn't about, for me, Aetna or Healthy Blue or any of that. It's about the process. And I'm just flabbergasted that there's a point system for awarding this, and what I'm hearing, what I think I understand, is the possibility of a tie was never on anyone's radar. And so that very much surprises me, but once a tie occurred, I'm also hearing that there was no intentional discussion, or maybe that this is where my question's going to go, okay, we didn't consider that possibility out of the gate. Now that it's occurred, what should the process be? How will that be communicated? Were any other agencies that may have been in this boat, had this occur, were they consulted and said, hey, what did you do in this circumstance if there was a tie? I'm more concerned about that lack of planning for this process, but once it occurred, what steps were taken? So I guess my question is, you're standing there, Jane.
Sure.
Can you explain how that process, once we got to that point, how the tiebreaker process was determined?
Absolutely. So I actually think that there was indeed a discussion about a tiebreaker process at the very beginning of this RFP. If you look into some of the documents that I have filed with part of my testimony, and you look at the document that hopefully you have that is labeled timeline, and you look at the very first item on that list in the timeline, which dates back to August 24th of 2023, you will see that there was a very clear discussion between the Department of Administration, between KDHE, and with Mercer. And there was very clear guidance to Mercer to say that there is no need to develop a protocol in the event of a tied score. And the reason or the justification that was provided at that time was that they planned to bring bidders back to negotiate and for an oral presentation process. So they did consider that we could end up with a tie, but we don't need to set up a protocol for it because we'll figure it out later. And I think what's really troubling about it is by the time we fast forward all the way to May 7th, they are told by the Department of Administration they have to concentrate on the scoring. They cannot use the oral presentations because nothing was submitted in writing and that they were essentially too subjective. So what I started presenting to you in the previous committee meeting was that the scoring that was developed for the tie-breaking portion of this was arbitrary and capricious, and we don't know how they came up with it. There is no tie-breaking protocol on paper today. There's nothing that says that this is worth X points and that is worth Y points. It's just, there is no tie-breaking protocol, and we may not use the orals. And so somewhere between that evening where they're told that they have to concentrate on the scoring, what we now have is orals that can't be used, individual scores that have been deleted, and all we have to rely on is consensus scoring, and we need to hope that Mercer did a really great job of capturing all of the discussions appropriately. So I guess, I don't know if I'm fully answering your question, but I think this was a very sort of intentional and deliberate approach to not have a tie-breaking protocol, because they were going to make a decision, you know, regardless of the scoring, which of course begs the question of why have the scoring process in the first place? Why have 20 people commit months of time, all of these reviews, come up with all of this, you know, material in terms of how each MCO was ranked, when ultimately the PNC, which is just composed of 3 individuals, was just going to render a decision based on how they felt. It just doesn't make sense to me. And not only that, again, coming back to this has to be transparent, but also there has to be some degree of fairness in this process. If we can't rely on objective scoring criteria in order to come out with an outcome or a decision, what can we really rely on? I don't have an answer to that question. I don't know why Aetna was not chosen to be one of the MCOs to continue in the future of managed care in Kansas. I don't know why, and I would really like to know why, and I hope that as a committee that you do get to the bottom of why and also ensure that there are rules in the state in the future to eliminate any more opportunities for not only deletion of records, but for cherry picking and arbitrary scoring decision making that occurs, you know, within the span of 8 hours, but without anything to really rely on that's objective or fair.
If I may, Madam Chair, follow up. So thank you for referencing the timeline. I do have that now to reference. And so the timeline does reflect that on 8/24/2023, there's a quote.
Yep.
There, quote, "There is no need to develop a protocol in the event of a tied score," end quote. Do you know who said that, where that quote came from?
Yeah, absolutely. So if you look at the timeline that I provided to you, and by the way, I did it just because there's so much documents and I wanted it to be easy to follow, but you see that it references a document called Attachment A. And I submitted to you attachments A through I. And if you go to Attachment A, you will find a series of emails, and they're highlighted. But there's a back and forth discussion between Tracy Deal, Pat Doran, Todd Herman, Laura Howard, Christine Osterland, Adam Proffitt, Janet Stanek, Dan Timmerish, and Brian Vasquez. There were also Mercer attendees at this meeting that included Marjorie Alt, Lena Hilverda, I apologize if I mispronounced that, and Michelle Walker. And the topic one in that sort of email on August 24th, 2023 is the proposed evaluation process and scoring mechanism. And so, you know, they talked about wanting a transparent process, but there's a decision that is rendered by this committee of people that is documented by Mercer that says, and this is Mercer writing these notes, mind you, and it says, there's no need to develop a protocol in the event of a tied score. The PNC will distinguish bidders during the negotiation process with the ability to bring them back to the table for additional oral presentations. But there was absolutely no framework even established for what those oral presentations could be. We don't know that in those oral presentations that everybody was asked the same questions, and we don't know how those were graded, quite frankly. Plus, in addition to which, at the very end, they're told they can't even use oral presentations as part of their decision-making in the tiebreaker. I think it's very strange to have thought about a tiebreaker at the beginning and say there's just no reason to figure out a protocol. That to me feels like would be a very transparent and just way of doing it, to say, if we get into a tiebreaker situation, we're going to do these things, and we're going to let all the players know what those things are so that they can prepare themselves, so that they can go in and put their best foot forward in terms of a negotiation, and really, you know, establish why they feel that they should be the ultimate bidder that is selected. So I thought it was very interesting. It's further in this email chain, but Mercer kind of went back and said, are we sure about this? And they're like, yes, we're sure. So the names of the individuals who are all part of that committee are all in there in Attachment A. If you see a page that has a chart on it, starting with topic notes, decision follow-ups, there is a list at the top that says state attendees and Mercer attendees. We, Aetna, did not create these documents, by the way. This is not something that we wrote up. This was provided to us exactly like this.
Thank you. And so my last question is, the justification for not developing a protocol was that they planned to bring bidders back to negotiate and for oral, you know, presentation. You've addressed the oral presentation. Was there any bringing of the bidders back for negotiation?
No, and I think that's the other piece of this. I don't think that at the time that those orals were happening, I mean, we weren't even informed that, hey, we're in a tiebreaker situation and now we're going into this sort of overtime, like, moment. It seemed like it was just part of their process to get some additional information on some of the things that we had proposed. And so I think that the bringing them back part was the orals. I could be wrong. And again, I don't know how they were graded in the end.
Thank you, Madam Chair.
Representative Carpenter.
Thank you, Madam Chair. So my question is for Brian. Brian, I want to make sure that in 2018 that the same process was followed and those documents were destroyed. Now, you're absolutely sure?
I've asked that several times to several different people, and they basically tell me, yes, that was the same process.
But do you know that on your own?
Yeah, I'm sorry, sir?
Do you know that on your own?
I do not know that. That's all hearsay.
So it would be hearsay? And you really don't know if that was done or not?
No. And to be candid, it was just not an issue in 2018.
Don't disagree with you there. I'm just trying to make sure that you knew for sure that those documents were destroyed.
You know, it's the joys of being an attorney is that you hardly ever are a witness because you never witness it.
I get it, but we can call that hearsay. So you really don't know.
Right. Yeah. As far as of the various sources that I've talked with, pretty much they all agreed that those individual evaluation notes, they were destroyed, they were not kept, whatever words you want to use.
I get that, but I also have some information of people that were in that negotiations that say they would be appalled if those documents were destroyed.
It's, to maybe catch on to President Brown's comments, there is the Arizona decision that came down where this was an issue here a few years back. In fact, there was the Kentucky Supreme Court just finally issued their final decision on a procurement that began in like 2020 where individual evaluation notes were raised. So if you add Kansas to the list in the last 5 years, it's become an issue in 3 cases.
Thank you. Thank you very much for that.
Representative Berquist.
Thank you, Madam Chair. Just one more follow-up question for the council for KDHE. Thank you for your cooperation in the discussion. Mercer was the prime manager, is that correct, of the project of 3.0? Is that correct?
Yes.
And were they also for 2.0?
I believe they were as well. We did have the assistance of Boston Consulting this time, and Boston Consulting wasn't involved in 2.0 in 2018.
Okay. And so in being the manager, a managing organization, were they prime decision maker for activity that would be modified in the process?
I might twist your words a little bit and say something to the effect that these were their suggestions. Mercer is a national company. This is one of the many aspects that they do to help local and state governments, is help them with bids. And so they seem to have a model that they like to follow. And this is what they suggested to Kansas. The individual evaluation notes, I think, was just one of those items on their process, to be fair with you, sir.
One more. Do you know when they were what year they were brought into the process of the state's decision-making?
I'm hesitating, looking to the audience. If I remember right, we actually had the Mercer contract let, and it was also an RFP, and I think it came down in 2022. They were of assistance during 2023, as President Brown's notes and what you have before you show. They were active in the process in August, and to help design the RFP, I remember meetings personally for once, being involved with it beginning in May of 2023.
All right. Thank you, Madam Chair. Thank you, sir.
Committee, further questions? Representative Concanon.
Thank you, Madam Chair. Mr. Vasquez, on these, this thread of emails that I'm following, or that I'm looking at, in your comments, you've made it very clear that these were notes. And every reference to what was destroyed, it's calling it, they're called evaluation guides were destroyed. What's the difference in that? Because you've been very careful to say notes.
And you are correct. What I understand happened, and there is a person who will probably be deposed this week, who there were the questions that were being answered, and of these 36 questions, and then there were points that they wanted people to say, what do you think is good about this? What is not? Those were the evaluation guides. Copies of those evaluation guides were handed out to each one of the team members. They were blank, and then they were asked to write their notes on those. And so I could understand where the term could be swapped out and become confusing. But they were still blank pieces of paper kind of created by Mercer where they asked people to write their notes on.
Okay. Yeah, so it's guides or notes or what, semantics. So when you had your 4 groups, was that information ever shared between the groups, or did they all just turn those in?
Well, there was also the consensus, but like, for instance, there may have been a team that looked at network, network status, how are you going to develop your network? At the consensus, they would have discussed the 5 or 6 questions that dealt with network issues.
Within the 5 people on that team?
That's right. They would not have gotten into like the case scenarios or membership or other things like that.
So did that ever get shared with another team?
They were told not to, actually.
Okay, so they each turned their evaluations in. Then who tabulated that?
That was where Mercer helped, and what got actually tabulated, again, as I did for the representative, I might move your words a little bit. There wasn't really a tabulation. It was, you say, I want to give them a 5 for question number 5, and somebody else says, no, it's a 1, which is 0 points. They would sit down, and Mercer would help guide that discussion until all 5 members agreed, no, they are a 3. And that was what was created as the final consensus document that was, as I understand it, then released to the to the Procurement Negotiating Committee for their use, along with all of the other materials from the RFP, and finally the face-to-face presentations from the 4 bidders. And in this case, maybe I'll just be Captain Obvious here. The 2 entities that tied coming out of the technical review were both invited to the face-to-face negotiations before the personal committee. And this was where they had a chance to answer an additional 14 questions and present whatever else they wished to do over and above the RFP presentation themselves. The RFP documents they created were 1,000 to 1,500 pages. And so it was all of that, which is where they had a chance to put your best foot forward. And that's basically how the recommendation came down.
Okay, so I understood the consensus within the team. But there's a step there that I'm still not getting. So that team then turned all of their numbers into their consensus number.
Right.
And that all went to Mercer?
And Mercer is the one who prepared that document, as I understand the consensus team meetings. Then those individual notes that each team member had, they were then asked to turn them in to another KDHE employee, one for KDHE, one for KDADS, and then Mercer tracked them to make sure that those notes were then destroyed.
And when those numbers were all calculated that ended up in a tie, that was done by Mercer or by
Yes.
KDHE? Okay.
Well, again, give you an example. I forget now what the exact number was, but say question 24 is worth 50 points. If you get a rating of 5, you get all 50 of those points. If you get a rating of 4, you get 75% of those points. A rating of 3 is 50% down to 1, which was 0. So it's the sort of thing where, depending upon how they came out of those 36 questions, there were several that, that got 5s, for particularly Sunflower and United. There were several of the other bidders that got 0 for a number of their points. But when you added all of those points together, at the end of the technical review process, Aetna and Healthy Blue had 522 points. I don't think they arrived at that number by answering exactly the same way. But we still had a tie.
I get that. My concern there is just who did it, who all was observing, did the process protect itself by having multiple people? Was there the ability for somebody to be able to skew it to one or another? All of those things make sense to me when you're choosing for something this huge. There's still a gray area there of how that part was done.
And in some ways, I wish I had been a witness to this, but my understanding was that there were the 5 team members plus an individual from Mercer helping to guide the process to get to a consensus. So I think in reality, there was probably only 6 or 7 in the room at most.
Okay. And I'm done talking about the consensus. I'm talking about the numbers, when you're actually adding up the numbers and to get to a tie. So, thank you. Thanks.
No, one thing I might add, Pat mentioned it, on the very good website that procurement has, all of these documents are out there and they're available for viewing on the public, including the technical review aspects of it. If you wanted to see where points were assigned and, you know, was one person better in this area than another.
Committee, are there further questions or comments? Okay, I'll start my list.
I may
Oh.
add some later. No.
That's fine. Well, no, I'm not the final question person. It's just, I kind of wait till I see if some other people ask my questions, and then I don't have to do them. And whomever wants to jump up and answer them. So I'm not going to call for specific. Well, actually, Brian, you mentioned that Mercer and Boston, so we had 2 consultants?
Yeah, Boston Consulting, yeah.
Why would we have 2 consultants?
You know, to be fair, I am not exactly sure. Mercer was specific, though, to the RFP. Boston Consulting, I think, was providing guidance on maybe how to rearrange KDHE or Kansas Medicaid in providing services, is what my understanding generally is.
Okay. And then I'm trying to understand if the scoring was not important, then why was it talked about? Why was the 522 even brought about? To tell anybody scores?
And it's the sort of thing where, to be absolutely fair, there was no scoring at all involved in 2.0. It was actually written comments.
Right.
And it's and in this case, you know, the scoring, I think, was thought as a way to provide a little bit more gradation or accuracy in understanding.
Well, I like the scoring process. I mean, I think it helps a lot.
It's a process. I think the other question I have, and this is just me, is that, you know, do other procurements of this size use scores? Or do they go something more, like when I wrote the bar exam, there wasn't any score involved. I had to write an essay. So.
Okay, then that leads me to, and when I talk about the consultant, I'll be both of them, so because they're not separate as far as I'm concerned, do we have in writing the process that the consultants laid out for this procurement?
I would need to go back and look at the RFP specific. That's not a contract that I worked on, to be candid.
Well, I think it's kind of important for us to know, because then it begs the question is, did it say in their process what could and would be destroyed?
I can ask that question, but I've had no one point that out to me.
Now, we heard earlier about accumulative scores being available. Is that correct?
That's correct.
Ryder, do we have those?
You have them? I don't have them with me, but I will be glad to provide them to the committee. They are on a public website right now, so I don't think there's any Cora exceptions or anything that apply to it.
All right, that would be good. Just go with staff, and then they'll kind of get it to. Can that something can be done? I'll get my tongue untied. Sent to us today.
Yes.
Like
In fact, if we are going to break for a lunch in a little bit, I'll go back to the office and ensure that copies are made and provided to the committee today.
Oh, that would be awesome. Well, and, okay, that would be awesome. Okay. I'm kind of trying to do these in a little bit of an order. Were the oral discussions included in the decision? Because what I'm seeing, it's almost like the oral was discussed by some important people, but yet it was said that because the oral wasn't in writing, it would not be basically counted.
There is an email that I believe President Brown had maybe highlighted where it did seem as if there was a direction for the initial draft of the PNC recommendation that included the feelings of the committee about the presentations, that needed to be rewritten and more focus made on the technical points.
So what do we have that was in writing that was pertinent to the decision from the bidders?
Well, there are the notes that have been provided through Cora that the Secretary Howard and Secretary Stanek have provided. But if you are looking specifically at the PNC recommendation, other than the scores, there was also the pros and cons that were written about each of the bidders, which went maybe more to the, a little bit more other than just a technical scoring. But that would be the only thing that I would kind of point to. I do believe there are some comments in there, but I think they were, this was a stronger presentation or this was a weaker presentation.
But there had to also be somewhere in this process where the bidders had to provide some written information, correct?
Right.
So what would that have been?
Well, the written information, and again, other than the further answers that were done, I believe there was a series of written questions and then some oral questions that were asked. I think that was what was the PNC used. If you don't mind, instead of me stumbling around and saying something wrong, let me see if I can find that, and I will be glad to try to provide that to the committee.
That would be good. So then would we have a list of the oral questions?
I can provide those 14 questions, yes.
But we don't have anything in writing as to what their answers were.
Other than the notes of the secretaries, no, I don't think there would be anything in the PNC recommendation. Yeah, I see Pat shaking his head, so.
So the notes that we've all talked about were probably made for the oral questions.
That's right.
But those no longer exist.
Yeah.
Right.
If I remember, Secretary Stanek's was done on a legal pad, and I think she had close to 20 pages of notes, but as she has kind of relayed, unless you knew her note-taking style, they may not make the most sense to somebody else reading them.
So then the oral questions were only handled by both secretaries of KDADS and KDHE. It wasn't by these other members?
No, both of the secretaries were the ones asking questions. And of those 14 questions, some were specific to like Aetna or Healthy Blue. Others were to all four. The four that were brought in were Sunflower United, Aetna, and Healthy Blue.
Okay, but again, all those notes are gone. All we have is the questions.
Yeah.
Okay. And I'm not trying to beat it to death. I'm just formulating.
Oh, I understand.
Okay. All right.
It's.
Okay, so the oral really wasn't included, or supposedly wasn't.
Yeah. We do have the secretary's notes.
Okay, I think that would be good.
Okay.
Be helpful. Did D of A concentrate on scoring at all?
I'm sorry?
Did D of A concentrate on scoring? Department of Administration.
I'm not sure how to answer it. I don't say concentrate. I think Department of Administration allowed KDHE, with the assistance of Mercer, to develop the process. But I think as Pat has maybe indicated, I don't know that there are other RFPs of this size. Well, I don't think there is anything of this size in Kansas that use scoring. So.
Okay. Was there discussion, and if there was, with whom, on using network and overall technical scores?
I believe those were things that the PNC did consider, yes.
So do we have that in writing somewhere?
I think you'd have to look at the recommendation of where there was a discussion at one point where it discussed, you know, whether or not, like for instance, Healthy Blue ended up having the most points for network of any of the bidders. There were other areas where I believe Aetna had the most points in one area, and I forget now what area it was. Yeah, so it's the sort of thing, yes, points were used by the PNC.
Okay. So we should have at this time of where we're at in this process, if not all, a good share of contracts signed for networks. Would that be accurate?
Yeah, all three, we have 3 contracts signed right now with Healthy Blue, United, and Sunflower. Those were signed back in May.
For contract, for networks. I'm looking for the networks.
Oh, no.
Because if I understood correctly what I heard yesterday, there's an approval process for that network.
That's
I think with
right.
CMS maybe?
Yeah, there is a middle, and I can get that timeline. If I understand it, there is a presentation coming up from the 3 MCOs roughly middle of September, of which network adequacy is one of the items that's required by CMS to review. Okay. And we have to make a determination whether it is adequate and then provide that information on to CMS.
Okay, but we would be able to see those networks today.
As I understand it, I don't think those networks exist, to be candid, because I don't know that they've signed all, I don't know where they are in the process. Let me
Find out for us today?
I'll be glad to try.
All right, I'd appreciate that. Let's see. Do we, no, I've already asked that one. Okay, I guess I've hit those. I think one of the things, and I had staff pull up, because they can do it a lot quicker and highlight for me, being I'm not an attorney. You guys can go through the law books and just bam, bam, bam. But I'm really struggling when the information that was provided that's per statute for KORA is that public record means any recorded information, regardless of form, characteristics, or location that is made, maintained, or kept by, or is in the possession of, and I think this goes back to where Senator Peck was referring to earlier, any public agency or any officer or employee of a public agency pursuant to the officers or employees' officials' duties and is related to the functions, activities, programs, or operations of any public agency. Can any one of the 3 attorneys explain to me how KORA was not violated by destruction of notes or anything else in this process?
To be, again, fair, you're moving into more legal argument. You know, the 10,000-foot flyover that was argued for 4.5 hours, among other issues, Friday.
I haven't followed the court process.
It was exactly kind of the issue that you're bouncing around.
Okay. Did I ask you what the overall technical scores were? And because that was, I think, if I'm hearing the technical scores were different than the scoring.
The document I'm thinking of would show you the technical scores for all 7 bidders.
Okay.
And be fair, Sunflower was first, United was second. There was a pretty good separation. Then we get to Aetna and Healthy Blue at 522. CareSource was like low 501, something like that. And then the other 2 were substantially behind.
So that would be part of that cumulative scores that we're going to get?
That's correct,
okay.
ma'am.
Okay. Representative Berquist?
Thank you, ma'am. Do you know who tabulated the final scores?
My understanding, and I did not, going back to Representative Carpenter's kind of question, I did not observe this, but what has been told to me is during the discussion for consensus, the team was there, the Mercer person was there, they finally agreed on something, they agreed on what the pros and cons were, and that document was created as part of that last team meeting.
Thank you.
Okay. Representative Carpenter.
Thank you, Madam Chair. So I'm reading this email here. I visited with OPC today. Any electronic communication, including the written evaluation, cannot have rankings or weights to the questions or the MCOs. The evaluation document should focus on strengths and weaknesses, but not be tied to any number. And then this is kind of goes to motivation or whatever you want to call it. Everything in email is discoverable. So that, to me, speaks of deception. I mean, explain to me how you would say that is absolutely a deception there. They're telling that person, remember, anything you put in an email is discoverable. That adds to the situations that, you know, caused this not to be a transparent process.
It represents one communication between a KDHE employee and someone from Mercer.
What's that?
What you just read.
Right. But they're warning that person that anything they put in an email is discoverable and public record. Is that what you would say from that?
I don't view it as a warning. I just view it as a communication between the two individuals.
I agree, but I usually don't put everything in this email is going to be a matter of public record if I'm concerned about that. So that it just goes.
I can't speak for the KDHE person.
I get that. So, and then further on in another part here, it's completed through a transparent and consistent. The RFP is completed through a transparent and consistent process. It was emphasized that no changes in the evaluation process could be made once the RFP was distributed. So changes were made in the RFP after it was distributed. Is that not correct?
The RFP indicates that modifications can occur.
That's not what this says.
That's correct, that what you read there is inconsistent with what's in the RFP.
Really? Is that the RFP? Yeah, this is the RFP.
You're not I'm sorry, you're reading from an email.
I'm not. I'm reading right in here. Topic number 1, proposed evaluation process and scoring mechanism.
You're reading from notes of a meeting.
I'm not.
Go show him what you're looking at.
And then let me move on to one other thing here just before that. I'll come show you that here. Are you aware, this is an email from Janet Stanek to I'm not sure who, to Christine. Are you aware that Bonnie has indicated that the responses of the evaluators gave are not congruent with those of what would be a legitimate review and have asked for more justification for an excellent response or a minimally accepted response? We should probably chat.
She asked for greater explanation of why someone would receive a 5 versus a 3 versus a 1.
Okay.
Yes, the document that Representative Carpenter is referring to are minutes taken by Mercer of a meeting of state employees, including secretaries of departments, as well as individuals from Mercer. It does not represent what is in the RFP.
Okay. I guess I stand corrected. It's not part of the RFP. Thank you.
Committee, further questions or comments? Okay, one of the questions I've got to ask, and I know that you guys, you gentlemen's time and ladies, is valuable. The information we've asked you to bring back, which you've offered to do that, would you be able to meet with us again this afternoon if we can set a time for that?
Of course.
And answer questions on that information? I appreciate that a lot. So we'll take, and because we're going to break here for lunch when we're done right here. And
I will note that the timing of that follow-up may be important to Brian.
Okay.
He is participating in a deposition later this afternoon, so he may not be available.
would you guys, the other two, be able to answer any of the questions that we might have pertaining to those documents he's providing us or not?
Yes.
Okay. Because I'm looking at here, and we're set to hopefully end around 3, but that usually doesn't really happen. So there I go again. I've already set it up bad. I want to be, around your timelines, and if I had to move some of these, I would do that to do it. So if you guys think a good time would be.
I'm Sherry Deal. I'm Chief Counsel with KDADS, and I'm saying that with caution with the litigation. This is all, arguments before the judge. And the other thing is, we're dealing with notes of secretaries. I have enough trouble reading my secretary's notes. You guys would be sitting down and trying to read notes and asking us to interpret those notes. I would hesitate to do that in an open setting. So I can't say that I can answer questions. I can try to interpret notes. I cannot do that.
Well, and if you guys can't, whatever information that comes back to us this afternoon, if you can't answer, we understand that.
Okay.
We're not asking you to step over on that. And then it might be that, we find another day or another time and see if an executive session would provide us any benefit or not. I don't know, and I'm not going to make that decision right now.
Yeah.
So
Well,
whatever you can answer, just like what you've done here today, we're going to be respectful of the case that's out there. We all kind of wish it was all done and we were able to be all open and honest, but I appreciate what you've done here today. So we would be willing to accept that.
Okay.
So is there a time that you guys would like to set, or are you willing to operate on a 3 or between 3 and 4 time frame?
Brian can't come back. I can be available, but Brian cannot be here.
right,
He's the one that, KDHE is most important.
Oh,
So-
thank you.
Always makes you feel good when you hear those words, doesn't it, Brian?
Who's going in first?
I don't know if 3 would work today, honestly.
4 o'clock? Well, because Pat said that he thought he could answer some of the questions, because all we're going to talk about is the information you're going to try to get to us today.
Yeah, I will go ahead and try to do it, and I don't know if either Pat or Sherry have seen it, but the deposition for this afternoon has been moved.
Oh, it has?
Yes, so I have a little more time to do it, but basically, you're wanting the consensus reviews, as much information as you can from that, and the notes from the 2 secretaries from the face-to-face. Is there anything else, Chairman or Chairwoman, that you would like?
All right, you and Elizabeth have a list, and
I'm sorry?
I'm asking staff here to verify that what you just said is what I've requested, because my notes here aren't in order, like theirs will be.
Have you read do you have the bid response?
The what?
The bid protest response, do you have that?
I don't know that we do, or do we?
I think that explains as best as possible the different processes, that the scoring was basically how to get to second base, and then the PNC brought the different bidders home. There were written questions, and one more bidder was eliminated. 5 were originally invited to the table by the PNC to answer written questions. 1 was eliminated in that process, and then the 4 were asked to face-to-face to answer additional questions.
Okay. No, I think that would be helpful. And if you'll email everything to Arida, and then as soon as you can get it, then she can get it to Dave, who can then get it onto our S drive for us to be able to look at, because we try to do paperless instead of printing out a whole bunch of stuff. So we're not asking you to bring printed documents unless you think there's something that we should see that's printed versus coming in on a digital. And I know I'm putting stress on you, Dave, as well, but it wouldn't be the first time I did that to you. Arida?
I believe there was also a question about the network and where we are in that process.
Did you guys hear what Arida said? That's okay. Go ahead. We all have to do little sidebars, and it distracts sometimes. I get it.
I believe there was also a question about where we are in the network process for each of the bidders of the MCOs. Brian was going to look at where we were in the list of those in the networks for each of the current.
I think the question in the RP was development of the network. I don't think it was the question that's being asked by the committee. And I don't think that there's any document that's in the litigation that's an open record that has that information. Are you aware?
No, that's fine.
Yeah, because we're wanting to understand, because we're close to the open enrollment period. Now, some people may not view it that way, but to me, it's close. Because, all of us legislators sitting up here is, and you heard Representative Carpenter say this, is we're not so much worried about a specific provider as we are the people that we serve out there, because that's our responsibilities. So we're wanting to get an idea of we know what Sunflower and United's network, but with Healthy Blue being a new one, what's their network that they have out there? What have they shown you so far? Now, I know that they'll continue to add to that.
Yeah, I don't.
And I know that then you've got to wait for.
I don't think there's any public information to that available at this time.
Well, let me look at a response here from Secretary Stanek. Oh, I got to look at an email here. I thought it was in text, and it's not. Okay. What she had said in her response to my request was, is the intent of the added topic asking for networks more broadly with the new MCOs? Well, we only have one new MCO, and that's Healthy Blue. As those contracts are still pending and require CMS approval, I believe, and we can have staff look at it as well, but I believe that those become they're public documents if we're waiting for CMS approval. But you guys legally, again, I'm not an attorney, so we can get all that verified. So if you want to do verification on your side, and we'll have staff do that as well.
The original contract.
Yeah, so it was just a short response back on my request.
There's original contracts that were signed on, I don't remember the date, in May, that were signed, and those are public. We can provide those.
Well, we want to get an idea of what is the new network, what network is out there. Because because the other thing is it was concerning, and I think that was one of my questions is, how you could rate Healthy Blue higher on network when they're still building their network. We don't know what that network is, but we do know what Aetna's network is.
I can partially answer that, but let me start first with it. What I think you're asking is do they have a network of providers already, and how big is it?
Yes.
Okay. I don't know that we can answer that, but going back to your umbrella question of why did they rate so high on network The questions that were asked from the RFP were, how are you going to go about developing your network? And there were 5 questions, and I'll be glad to extract those and send them. But the questions were not related to how many providers do you have at this moment in time in your network. And I think that's maybe, and again, I'm putting typical attorney, putting words in Christine's mouth. That's why I think she was kind of saying, I can't answer that because we don't know what those are. There is a step during readiness review where they have to explain what their network is, and we have to make a determination of network adequacy, and then it's our opinion that is forwarded on to CMS with the contract that will be part of the review. And again, it's a fairly standard step. I will be glad to ask Christine specifically if she knows how many providers have been signed by really all 3 MCOs at this point. I would imagine United and Sunflower's network is pretty set, so.
No, I think that you clarified my question better than I asked it. So that's what I'm looking for. I don't want to see a list of who they are. That's irrelevant to me.
No, I understand.
I want to see
You
numbers
want
and-
raw numbers, because I
Yes.
remember from 2018, we got into that issue because I forget what it was, somewhere in the process, I knew that MCOA had 12,000 and then,
Okay.
and so something
Yeah,
like that.
no, I appreciate that. You asked my question better, or, you asked it better than I asked.
Just lucky.
Okay, so we can do 2 or 3 o'clock, whatever works best for you folks.
It's the sort of thing, I think I'm planning on being back here about 1. We could maybe take it up right after Christine does her presentation, because I think she's slated for your 1 o'clock time period.
Okay, that'll work, so we'll do it after that.
Okay, I appreciate it. Thank you.
And to the MCOs that are set for 2 o'clock, I believe you're all out here in the room. Is that a yes? I think I'm seeing nods. We're going to move you down so that we can be respectful of their times on this, because, this is kind of time sensitive for this committee, and it doesn't mean that your presentations aren't important, but we're going to have you present after them. Is that fine? And if not, let Arida know what's going on. So at this time, committee, we're going to recess for lunch, come back here by 1:05. Lunch is out here, and I apologize, it's probably cold now, but we know how to deal with that. So thank you very much for being here. We appreciate the assistance you provided. So we're recessed till 1:05.
All right, we're going to go ahead and get started. So first up, committee, we have Christine Osterland, Medicaid Director and Deputy Secretary for Agency Integration and Medicaid, to give us an update on the following items you see on your agenda. Welcome, Christine. It's good to see you.
All right, let me see. Is it on? Okay. Good afternoon, committee. Thank you for having me. The first slide it really is just the agenda of what I'm going over this afternoon. Some of them are new items, some of them are updates from our previous meeting. So if you go to slide 3, I don't know if y'all have the presentation, it's called KanCare Update.
Yep, give us just a minute.
Perfect.
All right, go ahead, hon.
Okay.
We can follow.
All right. So slide 3 and 4 are just kind of reminders of what we've covered in the last committee meeting. Just some information about the medically needy program. On slide 3, it's who it serves and kind of the age breakdown for the folks served by the medically needy program. Kind of the primary thing to remember about medically needy is it's a program for individuals who exceed our regular Medicaid eligibility threshold. So their income typically is too high to qualify for Medicaid. If you go on to slide 4, again, a reminder that currently in our medically needy program, the income limit has been frozen at $475 since 1996. It's based on an old aid to families and dependent children level back in that day. What that really means is I have to have enough in medical expenditures to spend my income down to $475 in order then for Medicaid to kick in, which of course we all know $475 is an extremely low amount. So we've presented 2 options to the committee of ways to address that issue. Option 1 is raising that threshold up to the SSI level, which is really around $970 some a month. So it about doubles, maybe a little bit more than doubles what the current threshold is. If we go to the next slide, one of the follow-up questions that I was asked at our last meeting was, how did we come up with that fiscal, which was about 1.8 million. So on slide 5, I kind of highlight how we came up with that. One is anybody in medically needy that's dual eligible was excluded, and that's because there are federal requirements that Medicaid is the payer of last resort. So typically, even if they have very high medical expenditures, because of what Medicare is covering, they don't hit our threshold. The other analysis that we did is we looked at the number of beneficiaries in medically needy who never submit a medical bill. So we aren't calculating their spend down because they're not incurring any cost. And so we call them zero beneficiaries. They were excluded. And then we looked at, for the folks on medically needy who we are month to month calculating their medical expenditures, we applied the new threshold to kind of determine how many more individuals would qualify for Medicaid under medically needy if we increase the threshold. And then just wanted to put a fact that there's really no impact from the public health emergency on our analysis, so we didn't have to worry about anything pre or post. So that's kind of a highlight of how we came up with the 1.8 million. It really comes down to, while more individuals would hit that Medicaid eligibility threshold at $975, it still wouldn't be everybody, and that's why that fiscal remains at about 1.8 million. The next slide is the option 2 that we presented. This slide is a repeat from last time, which is to eliminate the spend down. That is an option provided to us by the federal government, which essentially means they're eligible for Medicaid because we would disregard their spend down. I had mentioned that would create a disparity between our long-term care folks that actually qualify under traditional Medicaid, and there was some follow-up requested. So if you go to slide 7, This is an attempt to kind of explain how option 2 would create a disparity. So essentially, when anybody requests long-term care under Kansas Medicaid, we perform what's called the 300% test. Individuals who pass the 300% test qualify for long-term care under traditional Medicaid. And the issue becomes, and I think if you all remember Mr. Patton from yesterday, he talked about his wife's share of cost for the nursing home, which was over $1,000 a month. The problem is, if you qualify for traditional Medicaid, we cannot apply any disregard. We have to calculate that share of cost. It's a federal requirement. So essentially, if we implemented option 2 in medically needy, if I'm under traditional Medicaid, which means I'm less than 300%, and I qualify for Medicaid, I still have to calculate your share of cost for the nursing home. If you were above 300% and you qualify under medically needy, I could do a disregard and not have to do a share of cost. And so it becomes this issue where, again, some folks in our program would have a benefit of a disregard and some would not. And so that's kind of why, from an agency perspective, we really don't recommend option 2, just because, again, that would be very difficult for members to understand that I'm the lower income compared to you and I have a share of cost and you don't, but it all comes down to the federal rules of what you can disregard and in which programs you can apply disregards. And then the next slide, and then I'll pause for questions around medically needy, if you don't mind, Chair. The next slide, slide 8, was again a follow-up, and this is just what the fiscal would be for the state of Kansas if we were to eliminate the spend down altogether. And you can see there, all funds, it's about $61 million, and that's just essentially because 100% of folks would qualify for Medicaid right away, and we would start paying for their medical bills, under Medicaid. And so with that, I will pause for questions on medically needy.
Committee questions, Representative Carpenter.
Thank you, Madam Chair. Christine, thanks for this. I've struggled with this for, I'd like to think you did too, but anyway, it's complicated.
It is.
So how does Medicare come into this? Because I see on this chart here, there's 3,500 folks, 61 to 70. Is this just for long-term care, or is this?
No,
This is for medical.
Yeah, it's anybody.
Okay.
So it isn't just long-term care. The reason I focused on long-term care, though, was because that's the one group that if you're eligible for traditional Medicaid under long-term care, I don't have an option to do an income disregard for you. So if we applied that disregard to medically needy and got rid of their spend down, I can't, that's the one population that I can't do it for. And so that's just why we point out. But yes, there are duals in medically needy. Now, I will tell you that essentially they have extremely small, if any, claims just because Medicare pays first, and then we pay second.
That's what it is. So
Yeah,
they don't
yeah.
encumber any medical bills because, any
Yeah.
spend down because
Yes.
they're covered by.
Medicare, and we would only pay, if there was a differential, if the Medicare payment was lower than the Medicaid reimbursement, which essentially never happens. So yeah, so that's why they're excluded.
So they do, but they do have health insurance, Medicare.
Yes, they do.
Okay, so they're not insured.
Exactly.
Okay, and then second question, Madam Chair, just real quickly. So how do you figure that 300%?
Well, let's see if I can,
It's
so.
slide 7.
Yeah, so whenever someone applies for Medicaid, and I may have to phone a friend as we get into this, Yvonne. So when anybody applies for Medicaid for long-term care, so each of our programs have different rules, which makes it very, very complicated. But if you're applying for long-term care, there are higher asset limits. and there's higher income limits. So what we do is we're basically testing what we're getting back in all of our matches to see if you're meeting the threshold. And then if we can't do it electronically, we'll request information from you. But essentially what we're trying to do is figure out, can we get you under that 300% threshold so we can qualify you under traditional Medicaid. So long-term care just has higher income and resource standards than what you're used to hearing in the traditional Medicaid program.
And I'm sure, so you mean the 300% is a federal poverty level? What's the 300% mean?
Yeah, it's 300% of the federal poverty level.
Okay.
Yeah.
That's what,
Yeah.
for us lay people out here.
Yes.
Okay, so now I get it. So it's
Yeah,
300%.
yeah.
But you still do the look back and all that?
Yeah, those are federal requirements.
Right.
Yeah, about if someone transferred some assets, that you have to allow that period to go by. So yes.
And is that 5 years?
Yes.
Okay.
Most typically.
Okay, very good. Thank you. Thank you, Madam Chair.
Committee, further questions?
Okay.
Okay, I'm going to leave it to Representative Carpenter on that, because I'm just a little bit nervous on the removing the spin down, but I'll follow his lead. So thank you, Christine. Next one.
Okay. Let me get back up with my slides again. I don't know why I got turning pages. Getting ahead of myself here. The next slides, which are 10 through, I think, about, looks like 21, are our normal updates around the financial performance of our MCOs, claims payment, customer service. There really isn't anything from the last quarter that's really an outlier or anything, majorly different. But again, I wanted to pause to see if the committee had any specific questions on those normal quarterly stats that we provide.
Committee? Nothing, Representative Carpenter? He hasn't looked at it yet.
Okay.
So.
And if you do, you can just send me an email, but I will tell you, it's pretty consistent. There was really nothing that's, you look at that's an outlier. But again, if something, raises a question, feel free to reach out.
Okay, thank you.
And then next I'll cover, I don't think I have a slide for this, but it's the rate study. Just to kind of give a timing update of where we are. We are actually getting very close. In September is when we will start having results of our rate study. We are actually meeting with our vendor next week. I was getting a little bit nervous about getting all of this data in. And, as you know, we have a lot of codes and a lot of rates in the Medicaid program. And it was kind of a bit daunting to think of getting one, kind of massive study back at one time. So what we're going to do is we're going to meet with our vendor to try to kind of parse things into categories, if you will. So like one for like physician fee schedule, one for maybe HCBS. I don't know exactly how those categories are going to break down, but we're going to break the rate study down into categories. And then as those categories get complete, we'll go ahead and submit that information to you all. You can see it in smaller chunks, just like I will be able to, which will be very beneficial. But then what that also means is they get a section done, we can go ahead and start analyzing what it's telling us instead of waiting for everything to be done later in September. So I would say we're probably just a few weeks away from some of the first results coming in for the rate study. So we're very excited and anxious to see those. Any questions on the rate study?
Committee, Representative Carpenter.
Thank you, Madam Chair. I'll just take this moment. It probably doesn't fit in here very well, but I and Christine have been having a little bit of a back and forth here on the 9% increase that we were talking about earlier about the physician's rate. And so in the recommendations coming out of social services budget recommended 9%, but it also capped it was at 80% of Medicare. So, and that made sense because we actually had $3 million worth of provider rate, or what is it? Oh, I'm trying to think, codes.
Codes.
We had $3 million worth of codes that were paid over Medicare. And so I was going to subtract that off and then add that to the others. Well, in the proviso process, I just found out from Megan, they dropped that language. So it's 9%. It doesn't matter if that code is 100% and it can't be over 100% of Medicare anyway, but if it's 91%, it goes to 100% of Medicare. So we're all screwed up on those codes again. And I'm like, because I was like, what? I wrote that up and I said 9% on, and she's like, here's what I'm doing.
Yeah.
And then she's doing what the language got dropped out that was in there, and it just said 9% on every code.
Yep. We'll try again.
Yeah, I will. Top priority.
Yep.
Thank you.
Yep. All right, next we'll go into kind of eligibility and round unwinding. So slide 23 is kind of where we are with our eligibility application status. We've got just over 9,600 or almost 9,700 applications in-house. 1,061 are over 45 days, which is 11% of total applications. And then you can see 1,010 of those are in a pending status, which means we're waiting on information from the consumer. And since we published this and submitted it to the committee, we're actually below 1,000 now for the over 45. So that does continue to trend down, which is good. Next slide is our call center metrics. Really not a lot to say. Call center has been very stable since the very beginning parts of unwinding when, we really had that major issue over a year ago now. It was in April of 2023. But you can see here they've remained very consistent in their performance and very good statistics. The next slide is, we finished unwinding in May of 2024. We were one of the few states in the country that did not request an extension to unwinding. We were able to finish. During that time frame, enrollment reduced by just over 114,000, which was well within our range that we thought. What I want to focus on here is I talked to this committee a few times during unwinding about some of the good ideas for improvements that either came from our stakeholders or from the Medicaid staff. A lot of those we've been able to implement now, so I wanted to share. These are some early results, but I think they're indicative that we're on the right track. So if you go to slide 26, one of the things that happened in the very early part of unwinding is our volume of unsigned reviews. While I know it says only 3.25%, but what that means for those people in that bucket is essentially if they submit an unsigned review, they're going to get their Medicaid closed before they can get a signed one returned to us. So it's a big impact to those families. We did a lot of outreach after that issue surfaced. You'll see a big drop there. That's really our stakeholders getting the message out. But then the action that KDHE took is we actually moved the signature page because a renewal packet is big. It's typically 10, 12 pages long, and the signature page was about page 7 or 8. We moved that up to being right behind the introduction letter. Because for a person to submit a review, all they have to do is sign it. They don't have to fill anything else out, and we accept it as a good review, and we're not going to close their eligibility until we process it. And you can see since we've implemented that in May, those numbers now have gone from being at 1.5%, down to 0.06% in August. So we are seeing that movement of the signature page has made a big difference for our families. And it's also less stress on them because we're not trying to send a big review packet out for them, asking them to sign it. So again, we're pleased with that. The next couple slides focus on, we call it the proactive communication tool. This tool allows us to communicate with our members via text, email, outbound calls. They can pick all the options, one of the options of how they want to be communicated with. But what it really does, it lets us target messages to individuals. So if I submit your review or I put it in the mail, I can send you a text to say your review is in the mail. If you click this link, it can take them to the portal so they can go ahead and start their review process and they don't have to wait on the mail stream, which we know has its challenges. But I can really target messages to individual members based on their circumstances. So it doesn't have to be those bulk emails that I'm sending to, 20,000 people or bulk text messages. It's specific to that member's case. If you go to the next slide, so when we implemented this in July, and this recommendation really came about during unwinding as us and the stakeholders were talking about the need to be able to really individually communicate with our members. So we were able to, in July, when we rolled this out, to send out 78,000 messages, and that was really around getting folks to sign up for how they wanted to receive messages. They do have the ability to opt out. So if they don't want to be bothered by text or email or outbound calls, they can opt out if they want. And what I really want to cover is, if you go to the next slide, just some basic stats from our first kind of messaging, so that we were able to send 23,000 messages to 16,000 consumers. And the reason for the differential is someone may have signed up to get both text and email. So that's why you'll see a differential in the numbers. Other interesting statistic from this is 38% of the consumers answered an outbound voice call. Now, if we all know about telemarketers and how many of us are inclined to pick up the phone when I'm getting a call, that was a pretty astounding statistic to us, that 38% of those members actually answered that call and were able to receive that information. And we've had some good statistics regarding opt-out. You can see only 23 consumers out of 5,000 opted out of the text messages. So again, the opt-in rate, if you will, remains high, which is really encouraging. And then the next page, I won't go through all of these, but these were really, again, more of a visual of some of the, messages that we've been sending and some of the numbers of consumers that we've been reaching. So again, we're really hopeful that these results will continue. And probably the one that we're actually the most excited about is our self-service portal. We all know the problems with the mail system and members having to wait on mail, sending things to us, having to wait on mail. We do have a portal where if they sign up, everything happens instantaneously. Their review, it's time for their review. It goes live on the portal. They get notified. We're sending them a letter to say we need bank statements. It's all instantaneous, and our usage of that portal has not been good. Now, we're working on some redesign of it as well to make it more user-friendly. But when we did our first targeted messaging through our proactive communication, trying to encourage use of the portal, you can see that one big red spike that the day those messages went out, the number of linked user accounts in that couple-month window increased by 94,000. So we went from very minimal use to a lot of our members signing up, which we hope as we move forward will really, increase our ability to inform our members of what's happening, get them to respond quickly, and have what I call less of this churn, which is by the time I get the information in, the deadline is passed, and now I've got disruption in my eligibility. So again, all indications are these improvements are showing early signs of good results, and we'll continue to update you as we move forward. And that is the end of the eligibility update. I will take any questions.
All right, questions. I am going to go back because I overlooked Representative Reese on one previously, so we'll get to that, and then we'll come back to this one. Representative Reese.
Thank you, Madam Chair. Going back to the rates, will there be any new Medicaid rates opened up?
Medicare rates?
Medicaid.
Medicaid? Yeah, so we have the rate changes going in effect on 10/1 that Yvonne presented on this morning. I don't remember if we have any more changes happening 10/1. I know we have some new policies going in on January 1, but I can get you a list because Medicare added on January 1, we're implementing some codes for the FQHCs. It was a change on the Medicare side, which then we have to open up on the Medicaid side. But we can get you a list of what's going into effect between October 1 and really the early part of the year, because again, and I think to your point, we'll have to take that into consideration when we get the results because they would have been done, and then we'll already have some new codes that won't be a part of the rate study.
And I'm crossing my fingers, but I'm sure you're going to say no. The interpreter code is still closed?
Yeah, we don't cover the interpreter code. We have the MCOs do it through the administrative dollars.
Okay, and then I do have questions for the next sections.
For the one that we're on now? Okay, go ahead and do that, and then I'll go to Senator
Great.
Erickson.
Thank you, Madam Chair. So for all of the new proactive communications, that's all awesome. Is that also available in other languages, like the text messages, the emails?
Yes. Because we keep their language preference, and I'm going to confirm that, because we keep their language preference in keys, correct?
We do.
Yes. Yeah, English and Spanish. Right now, it's English and Spanish.
Okay, and same thing for the self-portal? Self-service portal?
Yes.
Okay.
Yeah.
All right. Thank you, Madam Chair.
Senator Erickson.
Thank you, Madam Chair. Thank you, Christine, for being here for the presentation. So just a quick question. I believe that illegal aliens are not eligible for Medicaid benefits. Is that correct?
Yeah, by and large, there is one program called SOBRA, which extends some emergency benefits only. I hate this term, but it is the term that CMS used, called aliens. But it is very limited. It is only for an emergency until they're stabilized, and then Medicaid does not pay beyond that. But yes, they are not eligible for traditional Medicaid.
What about non-citizens who have an application pending for legal asylum? Are they eligible for Medicaid or other welfare benefits?
So there are some codes, so it gets very, very nuanced. And so there are some codes where folks can come in from another country, have a certain status in their immigration that they would be eligible immediately for Medicaid. It's very small and narrow. Most people that come legally or illegally to this country, and I think that's what people don't even realize, is sometimes those coming in legally have a waiting period before they're eligible for Medicaid benefits. But it's all based on their immigration status, and those rules are set by CMS. But I'm happy to give you kind of some of the most common statuses that we see, and then which ones are eligible out of the gate, if you will, and then which ones the waiting period would apply to.
Thank you. And just one final question. Do you have any numbers for Kansas as to the impact of this? How many individuals have received either the emergency or the situation you're describing, say, in the last 2 to 3 years?
Yes, we should. Yes.
Okay, if we could get that, I'd appreciate it. Thank you, Madam Chair.
And I'll also put in there a definition of what that coverage is and what it's limited to for you.
Representative Carpenter.
Thank you, Madam Chair. And Christine, you may have somebody else here that can do this. So yesterday I had written down here, we had testimony that talking about the long-term care applications. And so where are we at on that? I mean, time-wise, they were complaining that we were sliding back into the old days.
So I will disagree with that. We're not even close to kind of quote unquote the old days. But I think the nuance here, and we've been trying to work with the nursing home associations on this. So how over 45 days is counted from an eligibility perspective is the day that that application arrives at the clearinghouse. That is day one. The day an eligibility decision is made, and I'm going to go on a denial in this case, that now it's over. If they resubmit documentation, the clock goes back to 0 because we rendered a decision. The nursing homes are measuring this on the day they're admitted to their facility, And if they get a denial, but they believe that they can submit supplemental information or they could take an action that would help them financially meet the criteria, they keep that 45-day clock running. So we're measuring apples and oranges. We measure per the CMS guidelines. They're measuring from date of admission to payment.
Payment or their eligibility?
Again, I can only speak to the ones that we get to us. You'll see some that will say it's 180 days because we've already denied it, but they haven't been paid yet, and so they're still, and so and again, I get why they're doing what they're doing. This is not a criticism because of course they're concerned about payment, but we are speaking past each other. We're using the same term of over 45 days, but we're defining it differently. So we're trying to work with them so we can get on the same page and, we can refer to things the same way. So there doesn't become these statistics, because if you look in the presentation, we only have 200 long-term care applications over 45 days. And while that may seem like a lot, some of those are legitimate. Like if someone's applying for Social Security, we actually get 90 days to process those. So there are legitimate reasons cases go past 45 days. So from our side, our numbers look about where you would expect them to be. They're looking at it from a payment perspective of I haven't been paid yet. And so we're talking two different languages. So we're trying to get on the same page with them so we can, because that also helps us resolve the issue, of what's happening that where these disconnects happen, where we've said they're not eligible and they're thinking they should be, so that we can really work through what those issues are and not sit here and kind of argue semantics, if you will.
Thank you for that. And then, and if they were eligible, then they would be back paid for that?
Yes.
Okay.
Anytime if we made an error and inappropriately denied somebody, we would definitely backdate. Now, if it wasn't our error, but let's say their circumstances changed, because that happens, because there are ways if you're denied eligibility, let's say you have a life insurance policy that puts you over. You can cash that life insurance policy out. Sometimes there's, again, a little waiting period that has to happen. But now you're going to meet the Medicaid eligibility. Depending on that lapse of time, I may not be able to go back to the date of admission. So again, if it's some of it just comes down to timing of how far back we can go. But if we made a mistake, issued a denial, they reached out to us, we reviewed the case, and absolutely it was our error, then yes, we would backdate them. And that does happen.
Very good. Thank you.
Committee, further questions? Senator Peck.
Thank you, Madam Chairman. Madam Deputy Secretary, I apologize if you covered this because I missed it. You talked fairly lengthy about text and text messages. I am curious as to why we would need to, what would be an example of a text message that we would send to Medicaid?
We would send them that, so every year they have to complete an annual review to determine if they're still eligible for Medicaid. So we would send them a text message to say, it's time for your review. Click the link here and submit your review so we can, obviously it'd be worded a lot better than that, but that would be an example. If we hadn't received their review back and they're getting close to having their Medicaid ended because we haven't received the review, we might send them a reminder of, hey, you really need to submit this or you're going to lose Medicaid eligibility. So it's not going to be every day or sometimes even every month, but it's going to be when those situations arise specific to their case that we need to communicate with them, so we can either do their review, it may be completing their application, maybe we're waiting on bank statements that we haven't received, and we do a quick reach out to say, hey, we need some information from you. So it'll be very targeted.
So these phone numbers that you have for text messages, are they available to other government agencies, or are they strictly something that is retained by KDHE?
Yeah, they're retained by KDHE in our eligibility system. We will share information with our MCO partners, but we don't share Medicaid data with external entities.
Even external government entities?
Yeah.
Correct?
Correct.
Okay. Thank you, Madam Chairman.
And one thing I will clarify with that, some of the reasons for that is that in Medicaid, you can get into domestic situations and, you know, custody issues. So there could be very specific reasons that someone's information, address, phone number, et cetera, not being shared for other purposes could be very important to protect, you know, some very tough family situations. And there's no way for us to really know, but that's why there is a lot of limitations on sharing.
Thank you, Madam Chair.
Committee, further questions? All right, seeing none.
All right, thank you.
That's it? You're over?
It's over.
That is so good.
I know
Thank
it.
you very much, Christine.
Thank
I
you.
appreciate it. Pat, do we have more information coming yet? Because Arida says she's got one email from you guys. Or Brian, whichever one. Oh, we got two now.
There's Pat Doran, Chief Counsel for the Department of Administration. There's one document that I referred to earlier that is part of the agency record that has not been forwarded to you. That is the Excel spreadsheet that shows by question how each bidder scored. What has been sent to you is a document that shows how each bidder scored in the 7 topical areas, but it does not break down the questions within each topical area. That's on that Excel spreadsheet that has not been sent to you.
But it's coming.
It's coming.
Okay, all right, that's fine. Okay, let's give just a minute here for Arida to get it to Dave, and Dave, so we can all see it here. So we'll have a little pause if you guys are good with that. Thank you.
What was that? Okay.
No, Dave's putting it on the S drive.
Madam Chair, while we're waiting, could I ask a quick question of Pat?
Sure, Senator
Okay.
Fagg.
Thank you, Madam Chairman. Pat, I was thinking after we got done this morning on Mercer, that email about handling documents that was threaded kind of thing, and was wondering if that was something that Mercer's a big enough outfit. Is that a standard policy that they do? Or the person that sent that email? I was kind of hung up on that one a little bit and wondered if anybody asked the question, is this a Mercer standard policy?
So the email does speak for itself. A project manager from Mercer is following up on activities that they expect will be accomplished. And the email just has the Mercer individual asking if things have been accomplished, and individuals at the state are responding yes or no. I have to believe it's part of their process since it's included in their follow-up emails, but I don't know officially if it is part of their process.
Thank you.
Thank you, Pat.
Madam Chair, I think Ms. Orr should have the spreadsheet by now. It has 3 different tabs, and I think that may be what the committee is getting to, where it is the 36 questions, and then it has the ratings from all 7 bidders. And then that way, that will give you maybe a little more detail on how they scored or how they came up with some of the points. I'm waiting to make sure if Ms. Orr has received already. While I'm here, or Pat is here, or Sherry is here, are there any other questions that we could perhaps answer for the committee?
Do we have any other questions that you may have been left over, like Senator Fagg had this morning, from this morning? Nope, I guess we're just going to question you on those documents, so. Appreciate your patience a lot on this.
Well, thank you for putting up with us, too.
No, you guys have done fine, so. If not, you would have known we were very unhappy. We got one up.
Madam Chair, may I also add that nothing has been sent to you regarding provider network.
Okay.
The contracts that Healthy Blue may have to develop its provider network, the state is currently not privy to. We're not a party to those contracts. They're not yet public contracts. We will be discussing those contracts with Healthy Blue as part of the readiness review in mid-September.
So those would probably be something we could see maybe at our October meeting, which is like the 22nd, 23rd, think? Because you guys go open enrollment, what, November?
November 1.
If you don't have them by then, I think you're in trouble.
Again, it's part of the readiness review to go over that with them.
Okay, thank you. Where'd you find yours at? Is it Manning?
Is it there, lady? KanCare RFP technical evaluation.
Well, why don't I see that?
You need to refresh.
It's Manning?
No, it's
No?
KanCare RFP.
It's the bottom one on,
It's not showing.
Is that 52?
it's on mine.
Is it 52?
That's on mine.
Well,
No, it's.
always have to help my elders right here.
What did she say?
Something about helping my elders.
Oh, is that what she said? Maybe that made her day.
No, honey, you look a lot better than I would at your age, so. Okay, I think the first one that we've got, and if you guys want to go in a different order, we're fine with that, is we have the MCO, copy of the MCO RFP.
And what you should have received are the questions that the bidders had to answer regarding building a network.
Okay, so that's just the total of the scoring.
We're at a disadvantage. You're looking at something and I am not.
Okay, we'll have,
As we all do. Ask Dave how many times I've said Dave.
So if you're looking at page 1 of 1, scoring summary, this sets forth the total scores for the 7 bidders.
Okay.
Tabs.
Okay, so then we can go to,
Copy?
well, we had looked at it, that's just the total scores. This is the one he was just talking about. It says copy.
On this spreadsheet, 3 tabs.
Get it? Everyone else have it?
Yeah. Okay, the next document that you have is titled Technical Proposal Evaluation Report and Procurement Negotiating Committee's Request for Cost Proposals dated March 27, 2024.
Okay, what I have is excerpt from technical review report regarding bidder. See, we all need help some days.
So you're looking at what I had described earlier. You have a chart showing the technical scores by topic areas. There were 7 topic areas, and the chart is color-coded to indicate who was the highest score in the particular topical area and who was the lowest score in the particular topical area.
And, right, and, we've agreed that we may ask questions you can't give answers to, but, I'm struggling a little bit when I look at the first screen up here. Do, 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 do. That you have a new bidder that has a higher score for a provider network than an existing bidder.
Sure.
And actually higher score than even the other 2 MCOs, United and Sunflower.
Remember, this is a competitive bidding process. Therefore,
Okay, you realize that's snacks for the next meeting.
Donuts. It's her glucose, where it doesn't count.
You didn't like the Chick-fil-A.
It's her glucose.
I'm sorry, we just,
that's fine,
if we
Madam
don't
Chairman.
laugh in our process, then we're in trouble, so apologize. Okay, go ahead.
This was a competitive, negotiated procurement process. Therefore, incumbents were not given advantage over non-incumbents on the topical areas. So in the provider network areas, it was questions about how you would build a network, not questions about your existing network.
Okay. And if anyone else has got questions, just let us know as we go through these slides. Senator Petty.
Thank you, Madam Chair. So your comment just a moment ago about it being a competitive bidding process. And so in order that coming in their RFP, so that would be true for any one of these. So when you talk about like the one that says member experience, that would be what the organization would be proposing they're going to provide as for member experience?
Yes, it would be about their experience in the Medicare market, Medicaid market. You know, it's possible the experience could be influenced by what you're doing right now, but it's generally about your experience.
Thank you.
Thank you, Madam Chair. Just curious, who set the total available points? How were the total points available determined?
That was part of the Mercer consulting arrangement. They worked with a team from KDHE and KDADS to first identify those 37 questions and then assign a scoring amount to those questions. And that potential maximum scoring amount was set forth in the RFP.
Okay, I guess my follow-up is it unusual for the number one offerer to score 73%? I mean, it looks a little bit alarming to me that, you know, we're awarding this based on offers scoring 52% of the total available points, or is that just not relevant at all?
The scores were part of the technical evaluation phase of the overall negotiated procurement process. So I mentioned before there were 3 phases: a mandatory phase that you met all the requirements that were for the RFP, a technical evaluation phase that relied on this point system, a cost proposal phase that depended upon follow-up questions that came out of the mandatory and technical evaluation phase, as well as the in-person meetings with each of the 4 bidders that were asked to come in, and then finally an assessment by the procurement negotiating committee of what was in the best interests of the state.
Thank you for that. But the technical phase scoring is what has kind of, this tie is kind of what's at the forefront of the concern brought before this committee. Is that correct?
It is the concern that has been raised by Aetna. It is not the concern of the state. The scoring was just part of that technical evaluation phase. There were other factors that went into the state's final selection and recommendation.
So one of those other factors then was the oral presentation, and there's no written documentation, but yet it wasn't given much weight. The oral, correct?
There was oral presentations, and as you've heard, 2 members of the Procurement Negotiating Committee took notes, and those have been provided to you. 1 member did not. That was Bonnie Edwards from the Office of Procurement and Contracting. So those reflect impressions, but, you know, further impressions were part of the discretion that was exercised by the Procurement Negotiating Committee.
Okay. Committee, further questions? Representative Carpenter.
So just to clarify, that's in the tie breaking?
There was no tiebreaker. There was a three-phased process, and the scores from the technical evaluation phase were part of the overall negotiated procurement process. There was no need for a tiebreaker because it was a negotiated procurement that would look at all phases of the process as well as what's in the best interest of the state of Kansas.
Wow. Maybe run that by me one more time. I'm a little dense here. So we've got these two folks that tied at 522. And we decided that it was in the best interest of the state to go with one of the tied people. I mean, explain that. I mean.
Do you mind if I get something to read to you that's part of the public record?
That's fine, of course. I'm a little slow.
This is from the award document, the recommendation from the PNC. The state established that the scores, strengths, and weaknesses of the bidders' responses to RFP technical questions were to be considered by the PNC, but would not, in and of themselves, be determinative of the PNC's recommendations to advance proposals to Phase 3 review of cost proposals, nor be determinative of PNC's recommendation of KanCare MCOs selected for award. In accordance with RFP Section 6, as a negotiated procurement pursuant to KSA 75-37102, selection and award of KanCare MCOs must be based upon the best interests of the state of Kansas.
I'm just curious why we would even have an RFP process then, if it's that arbitrary.
It is discretion, and there's been talk about arbitrary or subjective. The PNC looked to objective assessment of who scored highest in various categories and allowed that to be part of its overall decision-making.
You would think there would be something that would stick out that would have made that decision easier.
And I do encourage members of this committee to read the protest decision of Director Todd Herman that lays out the analysis of the state and explains how a negotiated procurement works.
Thank you.
Senator Erickson.
Thank you, Madam Chair, and I'm sorry if Representative Carpenter got to this. I'll just ask it directly. If there are three phases and the scoring was the part that was tied, it seems to me the other two phases would have brought to light someone who would have broken that technical tie, correct?
Again, it was an overall process. And you're correct, it included all three phases. That third phase included follow-up questions and answers from 5 of the original 7 MCOs. Based upon the answers to those follow-up questions, the field was winnowed down to 4, who were then asked to come in and participate in one-on-one meetings. You've heard that the 2 secretaries prepared 14 questions that were asked of the 4 bidders who came in, and based upon the assessment of their cost proposals that was actuarially examined, based upon how they performed in those one-on-one meetings, based upon the totality of what was examined by the Procurement Negotiating Committee, they exercised their discretion and recommended the 3 winners.
Okay, I'm trying to find it. I apologize. I've read a lot today, but I seem to recall an email from, I think, Bobby at KDH&E that highlighted that during this process, they had to focus on the scoring. Are you familiar with the email? I'm trying to find it, so I
I have
apologize.
seen that email. It was submitted along with the materials provided by Aetna.
Okay, so they had to focus on, can you shed any light on that particular statement that they had to focus on the scoring?
I cannot, I was not involved in the process at that point in time.
Thank you. Thank you, Madam Chair.
Committee, further questions?
Madam Chair, can you hear me?
Yes, Senator Baumgartner.
Thank you, Madam Chair. I do have a couple of questions, if you don't mind.
That would be fine.
Thank you. So my network has been a little spotty, so there have been times that things have stalled, and I just wanted to go back. Was there an RFP process that led to the state hiring Mercer?
Yes, they were engaged as part of the Office of Procurement and Contracting's process.
Okay, but the RFP that selected Mercer specifically was for the process for picking the MCOs, is that correct? Or have they provided other services than this process?
I do not know. The contract was entered into between Mercer and KDHE and KDADS. I believe the contract predated the beginning of this particular RFP process.
Okay. And what was the contract amount? What was the dollar amount?
I do not know.
Madam Chair, I would like to know what Mercer has been paid for this process. And the reason I would like to know that, because it does get back to the whole guidelines of not having put into place an action if there were a tie. And I would like to have a little bit more information because legislators have brought up the term discretion and arbitrary, and it's kind of been bantered back and forth, I think, in some disagreement with the attorneys. But scoring is the only way in which you control, to some extent, things being arbitrary. So there was not any scoring in the third process? Am I correct in that?
Correct.
Okay. So how was it if there wasn't scoring in the third step, stage 3 of the process? How was it that it came to the results? Because obviously the fact that there was a tie didn't matter. So how did they come up with the results in a way that wouldn't be called arbitrary if there is nothing quantifiable?
The award decision of the PNC, as well as the final agency action taken by Todd Herman, the director of the Office of Contracting and Procurement, laid out what occurred in that third phase. It involved asking follow-up questions of 5 of the 7 bidders, then asking 4 of those 5 to come in for one-on-one interviews where further questions were asked. Along with that, the cost proposals that were submitted were analyzed and reviewed by the state's actuaries as well as the departments. And then the impressions of the PNC from those one-on-one meetings was all taken into consideration?
I think this is at least the third or fourth time that I've heard you step through that process, but it doesn't give us any indication of what actions were taken by Mercer, or by, I guess you could say, the Department of Administration to assure that the outcome wasn't arbitrary.
In the award decision issued by the Procurement Negotiating Committee, it listed distinguishing factors regarding the scores. It listed distinguishing strengths and weaknesses of Aetna and Healthy Blue relative to the total questions in the RFP, as well as the follow-up questions that were submitted in phase 3. And finally, the best interest of the state was considered.
And how did they quantify the best interest of the state? That gets back to what is quantifiable. What was quantified as the best interest of the state? And that's my last question, Madam Chair. Thank you.
Sure. And I understand the question, and it is part of the negotiated procurement process that the Procurement Negotiating Committee has this discretion to weigh all these factors, including what's in the best interest of the state, something that's provided in the statute regarding a negotiated procurement to reach their decision.
Okay. And you're looking off of this timeline that we've been reviewing here, there was an email from Todd Herman on May 17th at 4:23 to Dan Timish and Bonnie Edwards and Seth Adamson. And he says, nothing about this RFP has gone like a normal RFP in the office would go.
As you heard earlier, KanCare 2.0 did not include a points system. It did not include all of the same procedures and processes of 3.0. So that was the only comparable that Mr. Herman had to compare to. Other RFPs do not proceed with a defined process like this from a consultant.
Okay. Committee, further questions? All right, seeing none. I want to thank you guys very much for, coming back and bringing us these documentations and being able to answer everything that you could answer. So I want to thank all three of you very much for what you've done today.
Thank you for the opportunity to testify.
You bet. You're welcome anytime. Okay, committee, and we'll have staff work on language on this. It would be my recommendation, we don't get to impact what's going to happen on the final product, but It appears to me, and I would like to hear discussion on it if you disagree with it, is that depending upon who is in place at what time, the procurement process can be almost anything and done anyway. And I think that on some of the larger ones, and I think that, we can decide what should be that, that floor, that we say, okay, if a procurement is going to be X number of dollars, then it has to follow these guidelines. It has to include these things in it. And we'd have, between now and October, we can have, staff give us some ideas. If you've got some ideas that you'd like to share with staff, that you share it with Orida or Jenna. And let's see if we can't work up something that we would recommend for the legislature to look at next session for a bill to introduce that floor. Questions, discussion, comments? Senator Petty.
I'm trying to understand what you're recommending. So you're recommending having a bill that speaks specifically in generalities to any kind of procurement that the state does, no matter what the department is, whether it's Department of Transportation, Department of Health and Environment, Department of Administration, that there is a set process that they would have to go through to put out any kind of a RFP?
Well, that's one way to look at it, or, it might be just as simple as saying that during the procurement process, no notes, nothing can be destroyed in the process. The destruction of documents is what's really raised a whole lot of questions, and then some of the emails that are going back and forth. And lack of transparency, which has, and I don't care if it's a Republican governor, it's a Democrat governor, it's irrelevant to me. We as legislators are closer to the people. We have a responsibility to them every 2 and 4 years that they expect transparency from us. And I think that we need to make sure that we provide that. There's, every day it just seems like there's more distrust, and more distrust of government. And I don't want to see that happen in Kansas because I just think it's wrong. So maybe it's, like I said, it could be just as simple as saying that no procurement process or RFPs or anything other terms that we have to put in there so that we're not playing with words. No documents at all can be gotten rid of. Because that's created a lot of where we're at today.
Well, it's become the focus of where, for some, where we're at today,
You
but
don't see that as a problem, Senator, destroying documents? Because I guarantee you today, if it was Governor Brownback and he did this, all hell would be breaking loose all over his head.
well, we're actually doing that. We actually had a procurement process that went out a year late because of a Republican administration, so legislators. So we could have already our MCOs in place and doing, they're under a new contract already, but we're
And a
not, we
committee
don't.
could have taken that issue up, Senator, too, and I don't remember reading all that. Maybe it's something that I overlooked at the time. But I don't care if it's a Republican or a Democrat governor, and that's the way I have always operated for 26 years as a legislator. I operate what's in the best interest of the people. And somewhere along the line, this procurement process went off the rails. And destruction of any document during this process is just flat wrong. And why a consulting firm, Mercer and Boston, and I did notice that in, I think it was the Medicaid document that you guys provided, it talked about Mercer as the consultant, but I didn't see Boston in there, so just, that was confusing to me, but that any consulting firm would think that it's okay to destroy documents, or that a consulting firm would think it's okay that you don't have to have a process of a tiebreaker. Because some of us sit here, that sit here on this committee, we either are or we've been business people, and we understand how to, or we've dealt with, different contracts and things over the years and procurements. We wouldn't operate this way.
I'm just concerned about if we look at a piece of legislation that has a broad implication to any kind of RFP that any department deals with, I think we'd need to be very sensitive that we may be delaying And I think everybody that gets elected is concerned about the best use of representing Kansans and making the best use of the funds that are available, but delaying the process so that it really ties the hands of government moving forward for the best interests of Kansas and not helping.
Well, and that's why, Senator, that we have a legislative process. A bill is drafted, a bill is introduced, and it goes through the entire hearing process. Because I know from experience in working bills, I actually had one during this last legislative session that when we held the hearing, it was a nightmare. So we had to pull back, reevaluate, look at what we were dealing with, and we actually came in and did another hearing in a roundtable format with the experts that this was going to impact and affect, and then we finally found out how we needed to draft that bill. And it happened. It goes through the legislative process. We're just introducing a bill. We're not going to say that it's going to pass. And then you start picking it apart, and then you start hearing from the different people that deal with these procurements from all these different agencies, and they may come in and say, we're all wet. Then maybe that's the end result. But I don't think that this committee or any legislative committee that has the opportunity to look at this should just sit silent on it. Destruction of documents is wrong. We're taught that in business. We're taught that as legislators. So I guess I'm trying to understand where you see fault with introducing a bill and let it go through the legislative process and be heard and vetted and everything else from both chambers as far as that goes. And then the governor decides whether, she wants to sign it or not.
Madam Chair, you asked for comments. I
Yeah.
provided my comments.
Yeah, that's fine.
And I stand by them.
Okay, Representative Reese.
Thank you, Madam Chair. And Madam Chair, these questions are, I'm asking of you because I think you can probably answer them better than somebody else can, unless it's our lawyers here. One, whether there have been issues with other procurements that have happened, so is this a pattern that we're looking at? It's that whole thing is, absolutely the destroying of the documents, that should not have happened. But, is this, I guess I don't want us to have a knee-jerk response so much, but a very thoughtful response. Is there another way of saying what you said just a minute ago, that it may be simply said that you don't destroy documents? Is there a way of doing that without going through the legislative process and having this opened up to the whole legislature that could really make the procurement process, that there would be the possibility of the procurement process becoming even more complicated than what it is? And because it sounds like if we could just say, don't destroy the documents, and if there's going to be a tiebreaker, have a very clear plan of what that is without having to bring a lot of other people's into the cookie jar.
Well, and that's why I'm saying we don't come up with that wording today of what that would look like, because I don't know right off the top of my head. This is just what I kind of gathered that we need to look at this path. So the suggestion would be that between now and our meeting in October, that, any legislators that want to engage and be involved and help this process, is that hopefully all those people that are online listening to us and monitoring what's going on today will provide their input to our staff, and then we can work with the staff and with revisers and see what that wording is. I don't know what it is today. So I'm throwing out some generalities, and then hopefully we can come back with a process, because I understand about slowing it down. And so that also makes it important. That's why you set any procurement above $200 million, $300 million, because you don't want to mess with any of the small ones. That's a whole different process. So I understand what you're saying. I don't want to just throw out and carte blanche say this is what the committee wants to do. I want us to get input, because I'm not an expert in this at all. No, yeah, I think some of you all have a little bit more experience with it than I do, is I want to hear from the experts. So I think if the procurement office, Department of Administration wants to provide input, I want to welcome that. I want to hear from the experts on it.
Including whether we could go about this a different way.
Oh, absolutely.
Yeah, okay.
No, I'm open to that.
All right, thank you. Thank you,
I
Madam
see
Chair.
what you're saying, yeah. Thank you. Representative Ballard.
Thank you, Madam Chair. I would want us to look at all options that are really available to us. The destroying of documents really has me a little disturbed. Because when you destroy the documents, whether it was legitimate or not, most people would say, how come they're not available? They must be hiding something, or or they wouldn't have done it. And that doesn't always have to be the case. So I think we need to get that clear so that we don't start thinking everybody who does it, or we take away the responsibility of a particular department to be able to make the final decision in the process. So I'm in favor of looking at all options that would eliminate something like this happening. A comment was made later, like, I'm really surprised that we had a tie. As a result, I sat here and I added up each column because I wanted to know myself. And I added up each of those areas that they were making, that they scored on. And they did come out 522 on both sides. I also looked at the other column for Healthy Blue. They actually scored higher on 5 areas. Aetna scored higher on 2 areas. So I was just looking at it, just analyzing it, but it was the discrepancies in the scores, and yet they still came out 522. So it is not rare that that would happen, especially if you only have like 7 to 10. It could easily happen because one could score much higher in one area and bring it up. So that was legitimate, and I just wanted to be able to look at that to see for myself in what areas they were highest in, and we're able to see that as well. So it's in the court's hands at this point, so we really don't have that much responsibility at this point that we can do anything about it. But at least when I looked at it, I could see legitimately where the scores were, in what areas, the topic areas were. So, I mean, all of that was, above board for some people who think there wasn't much transparency, which I had a concern with. And again, you can't treat the same procedure when you have a tie, or if you didn't even prepare for that. So that's what I think we need to address, what you said, basically, what would you do in the case of a tie? And also the transparency of not giving the impression that maybe you didn't want something to come to light when maybe that was not really what you had in mind at all. Maybe you were advised to do that without asking questions as to how it would look to the public or to the bidders at the time. So I would say we can look at areas, but not set definitely what it is and take it out of the hands of the people that directly have to be responsible for that area. Thank you.
Thank you. Senator Erickson.
Thank you, Madam Chair. You wanted some comments and some thoughts. My thought is, I don't know how we legislate leadership. Quite frankly, this is an executive branch who's overseeing these agencies. And when you have someone who, in my opinion, has so obviously dropped the ball on a process, I would like to know what the executive branch is saying about this. I'm glad as legislators we're taking a look at it, because I do think we are closest to the people, and we have a responsibility in the area of allocating those funds. And I don't appreciate allocating funds to agencies who are so blatantly dropping the ball. And I know there's a court case out there pending, but those are my comments. I don't know how we legislate leadership and who should be held accountable for the lack of transparency in this process, but it's very obvious to me that that's where the focus needs to be. And yes, there are things we should do as legislators. Can we legislate that in a bit? I don't know how you legislate common sense. I'm going to utterly embarrass my children. But I had a saying, and I apologize for the graphic nature of it, but my kids, if they're watching back home, they'll know because they'll finish this for me. I shouldn't have to tell my kids not to poop in the yard. Right? Parents? You're like, who would think to have to, who would have to try to tell supposedly competent professionals to have a transparent process and not to destroy documents? We should not have to tell that. If we do, we've got the wrong people in place. Madam Chair, those are my comments as to this whole situation. Some things I think we do need to look at, though, and we can flesh out and maybe help be productive in this process. Exactly where did the process fail? If this agency isn't asking those questions, again, how do we legislate leadership and common sense in this? I don't know that we can. I think we need to hold them accountable in the appropriate role of the legislature for this. But I also, what's glaringly absent to me is the response from the executive branch who's in charge of these agencies. And I would like to, at the appropriate time, Madam Chair, hear that response. And again, as a former educator, what are some best practices? Why weren't those followed? And why are we as a legislature paying, I'm sure, we haven't heard how much we paid those consultants, but whatever it was way too much. Thank you, Madam Chair.
Senator Fagg.
Thank you, Madam Chairman. I'd like to go back to my comments to what you said earlier. I really like the idea about moving forward with the procurement process and how we handle RFPs. Size makes a difference, complexity makes a difference. My thought was that maybe we need to see what other states are doing in this area. You know, that could be something done between now and October. I'd be interested in what Mercer would have to say about something like this. If they do a lot of this kind of stuff, I'd like to hear their answers to that. He might even have some large companies that do large procurements. So this is about moving forward and how do we do this properly to be cost effective and service efficient with what we're doing. So that's my comments. Thank you.
Representative Carpenter.
Thank you, Madam Chair. And again, this doesn't have anything to do with any of the MCOs in this process. This is the RFP process. None of us want to be dealing with this. I'm sure everybody here has something or someplace that they would rather be doing. But with that, we have a responsibility to our state for a fair and transparent RFP process. This will be a stain on our RFP process in our state for years to come. And it's very disappointing. You know, people always say, well, there ought to be a law. Well, I don't believe that. But there ought to be common sense that you don't destroy documents that you may need in the future and that kind of stuff. So this really, I'm just aggravated that we're dealing with this and we've spent so much time on this, and it should have never have happened like this. So that's my comment.
Representative Berquist.
Thank you, Madam Chair. The responsibility of the legislatures are a number of things. They're whatever the people call on us to do. But one of the things we do is to try to make objective processes that are easy and clear to advance. And we make subjective decisions on budget. But in that, we do it clear to the light of day and to every voter. But the process is sometimes the smallest expenses get the most attention and get beat to death. And one of the largest expenses in the state, probably historically, is this type of expense we're talking about right now. And so if we turn our back and ignore it because it's too large to understand, or because it seems to be too undercover to be able to discover, that's not acceptable I think, the senator from Wichita, or from Wichita, that actually said it well. We have to have process. We're process people. We're trying to make good government for the people of the state of Kansas. And if we let money go by the billions, not because it's not going to get spent anyway, but if we make decisions based on, oh well, or on even a slanted decision, we don't know. But we do know that it's not clear, because there was an intentional effort to hide things so that things couldn't be seen. Talk about transparency, there's none there. And I hope to be a part of the process to continue in the next coming weeks to try to come up with something for next year's legislature to do something just to address this, so people don't say, what in the world did you guys do? You made a lot of noise, but did you do anything about it? And I'm appalled. I've only found out about this in recent months, but when we asked for the records to be provided, we were not even told they weren't available. And that's disgusting. That's a disgusting part of the process, because it is not truthful. And so there's such a big problem here that there's more to uncover, and the state deserves its very best from us and from everybody we work with. And thank you very much.
Committee, further questions or comments? I just want to reiterate that it's important for us to figure out where this failed and how we can make sure that it doesn't fail like this again. Second of all, between now and the October meeting, I welcome any legislators on this committee. I'll definitely want to participate. And I ask, whether it's KDHE, whether it's KDADS, Department of Administration wants to sit down with us, and let's see if we can't find a path forward on this. I appreciate the attorneys being here today, and I felt like they were very, tried to be as helpful as they could where they couldn't. It's because of what, the nature of being in court does. And I would welcome their input as well. How could we make our procurement and our RFP process so that no matter who the staff is, no matter who the governor is, we know that it's going to be a fair and a transparent process. That's all we're asking for here today. And, we're not going to change in this committee who the MCOs are. That's not our job to do. But it is our job to make sure that whatever process is used for anything is done properly. So I hope that everyone understands that. And again, thank you for the three attorneys being here today and for coming back and providing us documents at the last minute. We definitely appreciated that. So please let everyone know we're welcome to hear this. We want anybody at the table help us make a fairer process so that Kansas doesn't end up in the limelight again like this. All right. Committee, now we're going to move on to some other things we're a little more familiar with. And I appreciate our MCOs being flexible with this for us today. So we're going to do an update for our MCOs and discussion on dual special needs. And up first is Michael Steffens, President and CEO of Sunflower Health. Welcome, Michael. You've had a long day sitting out there in those hard seats. I did that for 2 days one time and said, never again. There's no cushions there.
I chose instead to be thankful because an air-conditioned room today.
There you go.
Madam Chairwoman, in light of, pardon me?
Your mic on?
Yes.
Oh, you got to get
Thank you.
closer, Michael.
Oh, I'll get closer. Can you hear me?
You're too soft. You're not like some of us.
Madam Chairwoman, in light of the lateness of the hour and in a desire not to be tone deaf, we had an earlier topic that I think we'll defer to the next meeting. We're at a future meeting, we would love to share with you something that we've done in response to feedback from this committee over the last year about the need to focus more on our rural communities and improving access to care and listening to some of the special challenges that they have. But if you'll forgive us, we'd like to defer that to a future meeting, given the shortness of time. You also asked that we speak to the dual special needs program, and I'd like to invite Sarah Kurgan, who is our Senior Director of Operations, to respond to that topic for the committee.
Committee, is there any objection to his request? All right, seeing none, we're fine. Welcome.
Thank you.
Tell us who you are and who you're with.
Yes, hi, Sarah Kurgan. I'm Director of Operations with Sunflower Health Plan. Thank you all for allowing me to be here today. As Michael shared, I feel like that's still too high. Is that better? Okay, thank you. I plan on sharing some of the benefit highlights pertaining to our DSNP product that we have here in the Kansas market for sunflower, as well as some of the overall advantages of Medicare Advantage plans. And so, in looking at the benefits that we have, those benefits and the products we have for Kansas, those include the core original Medicare They include the original Medicare core benefits, but in addition to that, they also include prescription drug coverage, as well as some additional extra supplemental benefits that really extend beyond those benefits that are included in our Medicaid plan. And so highlighting those benefits for you, just a couple of items I want to call out are we provide $0 premiums for all three of our plans here in the Kansas market. We also provide comprehensive dental coverage, which that dollar amount ranges anywhere from $3,000 up to unlimited, depending on the plan that those members select and the plans that they're eligible for. We also provide transportation benefits. That's the non-emergency medical transportation. We also provide meals that are post-acute stay after an individual discharges home from a hospital visit. We provide fitness programs. That could be anything from a gym membership as well as a at-home fitness kit that's delivered to them in their home. If they have access issues and things like that, we wanted to provide that benefit. I also want to highlight we have a Spendables card, which is a comprehensive benefit that includes over-the-counter access. Individuals can purchase items through a catalog, or they can also go out to the store and purchase items that are over-the-counter. But through that benefit, that ranges from $175 per month all the way up to $208 per month, again, depending on the plan that the individual selects and what they might be eligible for. If they don't utilize those dollar amounts within a given month, that can roll over. They have to utilize that, though, within the full calendar year. They can also utilize those dollars for things like rent, utilities assistance. They can pay for gas at the pump, childcare, et cetera. Our members that are enrolled in our DSNP plans in the Kansas market, when they're aligned, which means when they have both our plan for their Medicare and their Medicaid benefit, they can access additional coordination of care by collaborating with our care managers. All of our DSNP enrollees are assigned to a care manager within our health plan, but certainly when individuals are enrolled and have a plan elected through another carrier, we coordinate coverage with those carriers as well. Another thing I wanted to call out is we also provide, throughout the year, we facilitate a DSNP Enrollee Advisory Committee. We actually meet with our enrollees and we're soliciting information from them about their plan benefits and the product and design and just ease of access. We want to know what opportunities and improvements that we can make throughout the program year over year. So that's an iterative process. We share that information internally with our internal teams, whether that's the network team, our pharmacy team. We also share that information with our state partners. Moving into the next slide and the information that you see here, these are some national trends and numbers that I wanted to call out as it relates to just overall improved access to care. And when we think about a DSNP plan and a managed care model. And so, as I mentioned, coordinating that care, really the intent is to improve their access and the end result being greater health outcomes, working with not only the members, but also the providers and the key stakeholders to improve that quality access. So as you can see, based on the numbers here and these four key data highlights, overall access is improved for routine care at greater than 31%. These individuals that are enrolled in DSNP plans also have fewer challenges in accessing diagnostic and screening tests. They also have improved treatment access, and I think what's more astounding there is that bottom number of more than 72% are less likely to have difficulty in accessing care following an accident or illness. And that data is based on the Kaiser Family Foundation. Transitioning to our last slide here, I wanted to share a visual to the left. What you can see is a diabetes symptom and prevention guide. This is part of a quarterly newsletter that we send out. The content varies each quarter. This was our most recent newsletter that we sent to our DSNP enrollees. And really within the newsletter, and the rest of the slides are in the appendix of the presentation that we submitted. Our goal is to highlight information for our enrollees around what their benefits are, how they can access them, also highlight our quality programs. We also facilitate events out in the community, and so we provide that information to our enrollees. And so again, really focusing on how we improve health outcomes, working with our members and providers. What you can see here in the bulleted information is some of the program enhancements that we made as a result of the survey information that we facilitated this past year in 2023 and made those improvements in 2024. We're currently going through that process now, and we'll be making those updates and improvements for the upcoming plan year for 2025. Any questions for me?
Committee questions? All right, seeing none, thank you.
All right, thank you.
All right, next I have Stephanie Rasmussen, Vice President, Long-Term Care and External Relations. Oh, never mind. My head's still spinning from today, I apologize. Sarah, is Sarah? Nope, but we already did that. Angelique Hughes, Executive Director, Chief Duals Officer, Medicare Central and West Aetna. Welcome.
Thank you.
It's kind of nice when you get to check.
Good afternoon, Madam Chair and Committee. I am Angelique Hughes, Executive Director and Chief Duals Officer of Aetna's dual eligible special needs plans for our Mid-America and West territories. And I'm here today to tell you who we are and to show you what will happen to more than 10,000 Kansans in the absence of Aetna's dual eligible special needs plan in the state. And our desire is that if Aetna is no longer in the state, whatever we are replaced with is at least as good as what we currently offer the state. And I'd like to start with a member story to highlight this. If we can advance to slide 3, please. We'd like you to meet Mr. Aaron Miller. Of course, a fictitious member, or a real member, but the name has been changed to keep him anonymous. But Aaron is similar to many of our dual eligible special needs plans member. He's 83 years old. He lives in Leavenworth, Kansas. He has dealt with a stroke back in 2020. He deals with multiple chronic conditions, obstructive pulmonary disease, heart failure, high blood pressure, just to name a few. And his goal is he just wants to remain at home. He does not want to have to transition to a long-term care facility, for example. And that's where Aetna's dual eligible special needs plan care team comes in play. So we have very close care team engagement. 100% of our members, regardless of how they're risk stratified, whether they're considered a high-risk Tier 3 member, meaning they have multiple unmanaged chronic conditions, they have multiple visits to admissions to the hospital, skilled nursing facilities, whether they're a medium risk Tier 2 member, meaning they have some unmanaged conditions, or whether they're Tier 1, which is our more stable members. Each of our members is assigned to a care manager. So for Mr. Miller, Nikki is his registered nurse care manager and helps him with paperwork that's necessary so that Aetna can talk to his daughter and his wife who really want to help facilitate his care and be his advocate. So the care team taught Sarah, his wife, and Casey, his daughter, how to monitor his blood sugar. And they taught him how to check his feet. They also arranged for a visit to a podiatrist. His care team also taught Sarah and Casey how to monitor his heart failure and high blood pressure. And we also were able to give him a blood pressure cuff. In addition, the care team taught him how to use his extra benefits card. Our dual eligible special needs plans members in Kansas all receive an extra benefits card. And on that card, for example, a member can receive its preloaded credit card that has $250 per month that member can use towards paying for their electricity bill, towards getting an Uber if they want, towards going to the grocery store and buying healthy foods. So the care manager taught Mr. Miller's family how he can use his extra benefits card towards his health. And then they also arranged for in-home support for him. And for outcomes, the family was ecstatic. The wife, Sarah, was teary-eyed and expressed gratitude that Aetna had done all of this for their family. Mr. Miller was able to stay at home, so his goal was accomplished. So this is just one story of many. We have roughly 10,800 DSNP members in Kansas today. So this is just one of those stories. And if we can advance to slide 9, please. I just want to hone in a little bit so you can have a better understanding of the dual eligibles in Kansas that we help to support. This slide is showing demographics and chronic conditions of Kansans throughout the state. So when we're looking at duals in Kansas, for example, we look at the ethnicity. 74.7% are considered white, not Hispanic, followed by 12.7% Hispanic or Latino. Then we have 6.2% Black or African American, 3.3% 2 or more races, 3.2% Asian, 1.2% American Indian and Alaskan Native. And what I want to show next is looking at gender. It's almost a 50-50 mix, right? 49.9% are female, where 50.1% are male. And I also want to call out the average age. When you're looking at the dual eligible landscape in Kansas, the average person is under the age of 65. And 65 is the typical age that an individual would traditionally be eligible for Medicare. So what is this showing us? If the average person is 61.2 years in Kansas, that's letting us know that they've qualified for Medicare early due to a disability, and that this person also is very financially needy. So we have the majority of the individuals who would be eligible for a dual eligible special needs plan. We're seeing it's a very chronic condition, population, and financially needy. And looking on the right side of the slide, I'll just jump down to the last bullet, where it's showing that when we're looking at dual eligibles who are above the age of 65, 36.6 have over 6 chronic conditions at one time. So that is a lot for any single individual to have to manage. And that's where our care team comes into play. Now, for our care team, we're happy that we have several roles where the individuals live in Kansas. We have registered nurse case manager, social worker, behavioral health clinical case manager, senior health concierge analyst, case management analyst, case management specialist, transition of care associates, and associate care manager. So we have many individuals truly committed to Kansas, and they're here supporting our members. Now we can reverse in this PowerPoint now. We can go back to slide 4. I really just wanted to hone in on our care team first. Okay, we can advance to, so we're going to talk, and I'll go quickly, not to want to bore anyone, but just wanted to quickly go over Medicare Advantage and how DSNPs, which is what we call the dual eligible special needs plans for short, how they roll into Medicare Advantage. So first of all, Medicare is a federal health insurance program, as I mentioned earlier, for individuals generally age 65 and over. But if they have a disability, they can become eligible prior to the age of 65. And Medicare covers separate areas. Part A, your hospital and inpatient. Part B, outpatient services, such as doctor's appointments, durable medical equipment. And Part C is what we call Medicare Advantage. And within Medicare Advantage, if we go to the next slide, please. Within Medicare Advantage, we have what's called a dual eligible special needs plan, or DSNP for short. And a dual eligible special needs plan is a coordinated care plan that targets care specifically to individuals who are eligible for Medicare and Medicaid at the same time. So in this drawing here, we want to really emphasize that the dual eligible is that person eligible for Medicare and Medicaid. Next slide. Now, very quickly, what this is wanting to show on the Medicare Savings Program slide is just because a person is eligible for Medicare and they're in a dual eligible special needs plan, I also mentioned that they're eligible for Medicaid. But when we look at Medicaid, there's different categories within a state's Medicare Savings Program where an individual, the amount of assistance that the state gives towards Medicaid is determined. So an individual can be considered a qualified Medicare beneficiary, where the state is going to pay towards that person's Medicare Part A and B premiums. There's also what's called a qualified Medicare beneficiary plus. And what that means is the state not only pays towards those Medicare Part A and B premiums, but that individual also has access to that state's full suite of Medicaid benefits. We also have a specified low-income Medicare beneficiary, and that individual could receive some assistance towards Medicare Part B services. And then we have the qualifying individual and the qualified disabled and working individuals. But in the essence of time, we'll go on to the next slide, please. Next slide, thank you. This slide just demonstrates a breakdown within Kansas where individuals who are dually eligible fall as far as the Medicaid assistance that they receive. So we have the Quimby's that I mentioned, we have the Slimby's, we have the qualifying individuals, the qualified disabled working individuals, and then we see for those who are considered full duals, which means they receive that Medicaid financial assistance towards their Medicare cost shares, but in addition, they also have access to the state's full suite of Medicaid benefits. Next slide. And we went over this earlier. Next slide. Just want to highlight Aetna's proposed 2025 DSNP, which we have filed with the Centers for Medicare and Medicaid Services. We are looking to expand into 58 counties from the current 44 counties that we're in this year. And there are roughly 53,000 individuals who are dually eligible who would be within that service area. Now, within the state of Kansas, there are approximately 74,000 people who are dually eligible, and only about 24,000 are enrolled in a dual eligible special needs plan. And that's across whether they're with Sunflower, Aetna, United Healthcare. You've only got roughly a 33% penetration of dual eligibles who are enrolled in a dual eligible special needs plan. So the opportunity is tremendous. There's many vulnerable individuals in the state who can reap the benefits of being in a D-SNP. Next slide. I want to highlight, and we can actually stop at this slide, but there are some additional slides that you could take a look at in your leisure that just show Aetna's proposed 2025 footprint compared to our competitors. But I want to end here because this is talking about our D-SNP STARS rating. Medicare STARS ratings are very important. Medicare requires Medicare Advantage plans to be rated. It's on a 5-point scale, with 5 being an excellent plan and 1 being a poor plan. So Aetna's D-SNPs are 4-star rated. So these are above average plans next to the excellent scoring of a 5. And this means we are above average overall for member satisfaction, member complaints against our plan, how our providers handle our members, how our members manage those chronic conditions, such as what I mentioned earlier, and keeping our members healthy. So overall, looking to see that Aetna has a 4-star plan, it means we are a high-quality product in the state of Kansas. So I hope this helps present some of the strengths of Aetna's D-SNP, and I'll stop for questions.
Committee questions? Senator Petty.
Thank you for that presentation. It was very interesting. And I did, so this program, this D-SNP,
Yes.
Is it a required program or is it a value added?
So good question. So health plans are not required to offer D-SNPs. Medicare Advantage plans are not required to offer them. However, when a plan has a D-SNP, such as Aetna, typically they will add, on the Medicaid side, we say value added. On the Medicare side, we call them supplemental benefits. So with our D-SNP, and as earlier Sunflower mentioned as well with their D-SNP, there are supplemental benefits, such as the extra benefits card. We do offer transportation as well. So when we look at that, we expect our members to take advantage of the transportation that we offer. And then if they exhaust their D-SNP transportation, then they would tap into their Medicaid state benefit. We also offer vision, hearing, and other supplemental or value adds in our D-SNP.
Just as a follow-up, so then, so within that program, then, like, for example, that $250 a month extra benefit card, that's part of the value added then within the program?
Correct.
Thank you.
You're welcome.
Representative Ballard.
Thank you, Madam Chair. In your, we talk about D-SNP, but then we're talking about all these services, do you offer them, or do you purchase some of them from your Medicare in order to offer?
So if I understand correctly, so a D-SNP is a Medicare Advantage plan. Mm-hmm. So each year we have to, as an organization, get together and decide what plans or what benefits we are going to offer for the upcoming contract year. So for example, we'll decide, we might offer $2,500 in a dental benefit this year. Well, based upon, we're working with our actuaries, looking at our members' needs, what can we do next year? Are we going to enhance this? Can we take it to $3,000, for example? Or maybe based upon member utilization, if it's just not that high, we might lower that benefit and then be able to increase, for example, what we're putting on that extra benefits card. So I hope that answers your question. So it is a Medicare Advantage product, but we look at what benefits we want to add to it. So it does have the core Medicare Advantage benefits, Part A, so hospital, Part B, outpatient, And then I did not get to, on one of the initial slides, Part D, which is the Medicare Advantage prescription drugs, which is included in our D-SNPs.
I was impressed with the 4 stars. Now, who actually votes in order for you to get those stars? Are there people who use your services within the state of Kansas? But who votes for those?
So good question. So the Centers for Medicare and Medicaid Services sends out surveys for different components to the members. So we have, for example, a CAPS, or Consumer Assessment of Health Plan surveys, that goes out to members, and they are rating their experience with our plan. So for example, for that component, it's actually directly coming from the members.
Very nice. Thank you, Madam Chair.
Representative Reese.
Thank you, Madam Chair. I know transportation is a value-added benefit. How often is that provided?
So members, so for example, on one of the plans, we might have 40 one-way trips provided to the member. So they can use those 40 one-way trips whenever they like. And then if they exhaust that benefit, then the member could tap into the transportation benefit that's provided by the state through Medicaid. If that individual is what we call a full dole, where they have access to the state's full suite of benefits. And then also there's a benefit, so with our extra benefits card, in addition to the non-emergency medical transportation benefit, that member could use that card if they want, for example, for transportation, call an Uber or a Lyft. So that's an additional option that the member would have for transportation.
Madam Chair, if I can ask a follow-up question? Sure. So if it's a one-way, and so I'm going from my home to the doctor, and then I go from the doctor back home, that's 2 trips?
Correct.
Out of the 41?
Correct.
So you have 20 trips.
So you end up really with 20 round trips?
Yes, and that is correct. And we really do encourage our members to use their D-SNP plan in conjunction with their state Medicaid benefits. Right. So if they do exhaust that benefit, there is additional support for them. But yes, you are correct. With it being one way for round trip, for a 40 trip plan, they would be looking at 20 round trip visits.
Okay, thank you.
You're welcome.
Committee, further questions? But now, as an MCO, you don't sell the Medicare Advantage, or you do?
So Aetna does, so yes, so I represent Aetna's Medicare Advantage side of the house, where yes, we do sell the D-SNP, the Medicare Advantage, and then Jane Brown represents Aetna's Medicaid MCO side of the house.
So then Medicaid recipients on the disability side then go to private agents?
So for Medicaid benefits, so individuals who enroll in our D-SNP also have Medicaid. The way the state sets it up is members have a choice. So Aetna does have to have, for example, a managed care organization active in order for us to have a D-SNP. But the state does not require our Aetna D-SNP members, for example, to enroll also in our Aetna Medicaid. So that means we could have an Aetna Medicare Advantage D-SNP member who does have Aetna Medicaid or who has United Medicaid, for example. And the requirement, though, is that as a Medicare Advantage plan, the onus is on us, according to our state Medicare agency contract. So the contract that we have with state Medicaid agency and the D-SNP is that we are responsible for ensuring that the member is receiving their Medicaid benefits, and we're responsible for coordinating those benefits with the members. And our social workers, for example, will help members recertify for their Medicaid coverage. So even though the member may not be covered with us for Medicaid, it might have that coverage elsewhere, we are responsible for seeing that they're receiving their Medicaid coverage.
Right, but then we also have dual eligibles that purchase from private agents. Or
Yes,
get their
yes,
ma-
yes. So
Yeah,
as
that's
far
what
as,
I'm trying-
yes, so as far as enrolling in the actual dual eligible special needs plan, many of our members enroll through private agents.
Okay.
Correct.
Well, because when you looked at the numbers, going back to the chart with the ones that are eligible, but where you're at,
Yes.
and I'm not sure what the logistics are, but most Medicare agents don't like to deal with the dual eligible because they say there's a lot of difficulty. I don't know if that's in paperwork or what it is. So I think that's something that needs to be looked at. Is there something that can be more streamlined or make it easier? Because I know there's agents that want to work with that population, but there's others that don't have the time to work with that population, so.
Yes.
Well, they don't make any money.
Any further questions? Senator Fack.
Thank you, Madam Chairman. So each year, a person has an opportunity to re-up with you or to change to one of the other programs. Is that true?
Correct. For a DSNP member, correct.
So my question to you is, what kind of turnover do you have? You know, how often do you see as many come in, go out, or do they usually sign up, they're with you for a while?
That's a good question, and I can get that data, but I don't have it readily available. What I can say, however, is we started the year, we're growing, even though we're in August. I checked today, for example, and we've got 10,886 members, which has grown, from what we had in previous months. But as far as turnover, we can definitely get that information to see the longevity of our members.
Thank you.
Representative Reese? Representative Reese.
Thank you, Madam Chair. I had one more question. This is regarding your story about Mr. Miller. And it's on here about the care team helped him get a glucometer.
Yes.
Does Aetna, under the prescription part, do you cover the continuous glucose monitors or only the finger sticks?
It depends on the plan. So that would fall under durable medical equipment. So based upon the plan that the member's in, that would determine if they get that continuous glucose monitor. I don't want to misspeak right now without having that information in front of me. But I do know that some of our plans do offer the continuous glucose monitors.
Under regular Medicare, not under the Advantage plans, you have to be receiving insulin through a pump in order to get the continuous glucose. And the finger sticking is becoming a old technology now. So I was just curious about that. It's much better to have a continuous glucose monitor.
Agreed.
Well, and I think one thing that we need to understand is that in this population, Medicare is the first to pay. So anytime that you have a dual individual that is enrolled, then Medicare is first pay and then Medicaid is the second pay. So it's also savings on the Medicaid side of the dollars. And also to keep in mind, and this is what we might put on the spreadsheet. I think we took off less than we're adding now. But I think at our next meeting, it would be good for us to see what are the benefits in the Medicare Advantage plans for the DSNP programs, because it's all different. Because what you heard from her today, the Aetna program's going away. When they're no longer an MCO, it's done.
Yeah, I'm just assuming it's going to be the same for all of them.
It's not. No, they all have their own benefits that they take and provide, just like you have in the private Medicare market. Each Advantage plan is different, and each county is different, each state is different. I mean, it gets complicated out there, so. Any further questions, committee, or comments? All right, seeing none, thank you very much for being here today.
Thank you.
Appreciate it. Richard Sloma, Chief Medicare Officer and Vice President, Central Aetna. Welcome to committee.
Madam Chair, committee members, welcome. Just to follow up, and I share the sentiments with Sunflower. You know, I live in Iowa, and there's a hole in our safety net for the duals and the rural populations. And I'm passionate about it. My team's passionate about it. So I would welcome an invitation to work with your committee on looking at ways that we can close those holes in the net in our rural areas. A lot of the folks out in the rural areas don't have access to medical care like their counterparts in metro areas. That's a big problem. And the other problem with this population is that these folks really rely on centers of influence, your food banks, your low-income housing units, even your charitable organizations. They don't have access to the care that they should have, and I think it's a big problem in the United States, not just Kansas. So I welcome the opportunity to work with you. How do we address rural Americans and their health care needs? It's a big, big issue. So thank you. Any questions for me otherwise?
Questions? All right, seeing none, thank you very much.
All right,
And I
thank
agree
you.
with you on the rural side. That's a problem for all of Medicare, so.
Absolutely.
All right, then we have Kim Manning, Executive Director, Dual Complete Plan, United Healthcare, virtual.
Thank you, Madam Chair, and thank you for the opportunity to present today. Maria, will you be bringing my slides up?
It's in the presentation. Do we have it? Oh, okay. We're getting it.
Okay.
Some days, technology is just a little slower than other days.
That's true.
Hey, Will, that's just one piece we've never really looked at is the D-SNP. But there is complication. I'm going to see what Mark tells me those complications are. Because I know it's time consuming. That's why, like Mark with the volume he does, he can handle that. His agents that don't have the same volume. Yeah, because, Can I ask Etna another question real quick? Would you mind coming back up here, Angelique? It just dawned on me on something. Is it accurate that the dual eligibles Medicare side is done, renewal is every month, or there's changes that can be done every month?
So
There's something in that
currently,
complexity with every month, something or other, but I don't know the details.
in 2024, currently, there's a quarterly special enrollment period. So a person can switch their plan once per quarter until the annual enrollment period. So once September comes, they're frozen into that plan until the new year. Now, there's been some changes in Medicare regulations. So starting in 2025, there will be what's known as a monthly special enrollment period for states where there's the highly integrated dual eligible special needs plan and fully integrated dual eligible special needs plan. Without going too deep, Kansas is considered a highly integrated dual eligible special needs plan. So an individual can start with one carrier, and if that person wants to switch their Medicaid coverage the next month, they can do that, and then their D-SNP coverage would automatically align with whatever that Medicaid carrier is. So if someone, for example, started out with United, let's say on January 1st, and then decided for February they wanted to transition to Sunflower's Medicaid, they would then have Sunflower's D-SNP. And they could do that on a monthly basis as long, there's a caveat, as long as the state's Medicaid program allows a monthly Medicaid enrollment, because that transfer in between plans is going to align with what the state will allow. So some states only allow a person one time per year change in Medicaid. So that would be aligned with what Kansas would allow, if they do allow monthly enrollments or not. That will dictate how often the person can change plans. But from a Medicare perspective, they will allow, if the states allow, a monthly change beginning next year.
Then do they have to sign up for that each month? Or it'll automatically stay the same if they don't make any changes?
It would stay the same if they don't make any changes.
Okay, thank you very much.
Yes.
Christine, is the state going to offer that monthly change next year? And then how does that affect our duals?
So what happens in Medicaid is a Medicaid member is provided a 90-day open enrollment period annually where they can change anytime for any reason. Outside of that, the federal government requires under Medicaid that you allow what is known as good cause changes. And there's very specific reasons in the Code of Federal Regulations that we would need to allow a member to change plans outside of that open enrollment window. So that's where you get the monthly, you can get the monthly movement, because if someone meets one of those good cause criteria, by federal regulations, we have to allow them to change plans.
Do
you
you have that list of good cause, or is that something you can send to us?
Yeah, we can send it to you. One of them would be, like, for instance, if there was a issue with the provider and they were no longer contracting with a particular health plan, that would be a good cause reason to be able to change, where you and I would not be provided that opportunity in our health plans. That is a provision of Medicaid. But yes, we can get those to you.
Okay. And then one other question, because we had some confusion on the start for open enrollment this year on the contracts. When is that?
Yeah. So, okay. So there is, when you have a new MCO coming into the market, the federal government requires that you provide a minimum of a 60-day window prior to that start date for the folks to make a choice. Kansas has always just done 90 days. So that would be October 1. But to meet the federal requirement, we could go as late as November 1 to provide 60 days. But then what happens come January 1, once we start the new MCO contracts, everybody is afforded a 90-day open enrollment window. So essentially, what it equates to is from October 1 or November 1, whenever we start, to March 31st, that's really going to be their change window this year. It's just extended because of the transition.
Well, and I think that your contracts say November 1 for this year, so then that would mean they'd have the 60 days plus another 90 days,
Yes,
what you're
at the
saying.
end, yes.
Okay,
yes.
all right. Thank you.
And one of the reasons we do the 90 days, because our contract says 60, but we send the notices out a little bit sooner. The reason we do that is it allows us to stagger the mailings, because you can imagine if we tried to do 410,000 at one time, what would happen to the call center? So backing it up allows us to stagger those so it's not so overwhelming and we can provide the customer service we need to.
Okay, thank you.
Thank you.
Thank you, Annalee. Okay, do we have the presentation ready? All right. Now, Kim, we're ready.
Okay. Next slide.
See how it gets complicated on the Medicare stuff.
So this slide represents the individuals are eligible for dual plans if they both have Medicare and Medicaid. And they are adapted for people who meet income needs and special needs, such as those with disabilities. All decent plans include a prescription drug, Part D coverage, and supplemental benefits, which I'll go through in a moment. DSNPs provide the same, DSNPs position themselves to go over and above for dual eligible members, looking at products that provide them value-added supplemental benefits and then care coordination. Next slide. So our population, as the other two MCOs mentioned earlier, are complex and very diverse. So for those individuals over 65, more chronic conditions than we see with other members in our plans. 50% rate health status is fair to poor. And of those with poor, compared to 6% of other Medicare beneficiaries. And then for those under 65 with one or more disabilities, 39% of our overall decent population. Many of these individuals live in community or group home settings, and there is high rates of significant physical disabilities, AIDS, affective disorder, and then high utilization of some of our long-term services and supports that we have. Next slide. As others have mentioned, a DSNP is a Medicare Advantage plan for those who are duly eligible. All DSNPs include the prescription drug, but they also include hospital stays, doctor's visits, coordination of care. So a big piece and benefit of our DSNP plans is coordinating the care between Medicare and Medicaid, and then the additional benefits that we offer. Next slide. So I'd like to take a moment to really talk about the value of a DSNP plan to Medicaid. A big piece of our dual plans is we reduce barriers to care by supporting the social and personal needs for individuals. For example, many of these members have food insecurities, housing issues, and transportation issues. Those are the top 3 barriers that our members face every day. We can help these members with independent living. If they would like to live independently, our care team goes over and above to find those types of independent living that are safe and secure for a member. It allows the consumer to maximize their limited income with maximizing the benefits to address their particular needs. We do offer high value benefits and services to consumers that are typically not available for Medicare fee-for-service, Medicaid, or non-SNP plans. And then we utilize what we call navigators, just as you have navigators that would assist across a very complex system of healthcare services. Every member is assigned a navigator to help them with their day-to-day needs, and then also to help them coordinate benefits, make appointments to see either their primary care physician or any of the specialists that they need. Next slide. So for our Kansas members, we too offer dental plan. So currently for 2024, our members have $4,000 to put toward dental care. We offer vision, a $400 support for eyewear, 6 visits for foot care, 20 visits for a chiro visit. For non-emergency transportation, we offer 48 one-way trips. And then once they use our DSNP benefit, the Medicaid benefit, they can pick up. We have virtual visits, for many during COVID, virtual telehealth visits increased across all of our business products, and it continues to be used. We have a 24-hour nurse line, so a member can speak to a nurse, and many times they can provide medical advice so the member doesn't have to go to an ER or urgent care. We offer OTC, healthy food and utilities, $244 a month for our members. We have a fitness program that members can join many fitness facilities, and then also we give them a Fitbit. We have the personal emergency response system for any sort of fall that they can push a button and then receive emergency care. And then our hearing aids, individuals can receive $2,500 toward hearing aid units. Next slide. And this shows United Healthcare is currently in 69 counties supporting our individuals. And we also have within there 2 plans. So we have 2 HMOs. One is a 5-star plan and our other HMO is a 4-star plan. And I'll pause for any questions.
Committee, questions? All right, seeing none, Kim, thank you very much.
Thank you.
All right, committee, that concludes all the presentations that we have today. I have sent an email to our staff to give some thought to who we need to invite to the table. They will also then at some point send you out an email to see who would like to be interested in looking at this procurement issue. And then they'll look at, what stakeholders do we need at the table to have that discussion, and then we can figure out where we take and go from there, and see if there's a path forward on it. Is there anything else that anyone else wanted to bring up today or have added to the spreadsheet? Because I think Elizabeth and Wright are just waiting for more things on the list. Senator Petty.
I can't remember for sure if this was already on the list, but it had come up often about Mercer, and I just wondered if if our research staff can find out how, or through the procurement process, find out how often Mercer has been used as a consultant, I guess with the Department of Administration.
Well, I thought the Department of Administration said that they have a long-term contract with Mercer to do different consulting on different procurements. Is that what you're looking at, or?
Well, it came up repeatedly about Mercer as a consultant, how much it costs, and so I would like for us to have the information about if in fact they do have a long-term contract, how often they've been used, and with what departments.
All right. Got that, ladies? All right. Representative Reese. Well, he was saying you. Oh, you?
Do we have about an hour?
No.
You mean an hour more or an hour?
Yeah,
Yes,
you'll
I
be
do.
here all by yourself, Representative.
Which hour?
Representative Reese, did you have something?
Yes, it's just a general question. I don't know who can answer it. There's some information I would like for really the current 3 MCOs, if they could gather information for me regarding Spanish users through their interpreter services. But what I really need is like a email to each of the MCOs that I can call, I can contact, and I can send them an email. Can someone get that to me?
Yep, staff has it.
There you go. Thank you.
Is that it? Did you have something, Representative Berquist, or that was it? Okay. All right. Senator Fagg. Senator Fagg.
Thank you, Madam Chairman. Is this the right time? I was wanting to see about the committee looking at an introduction of some legislation.
For?
Okay. Legislation to allow the rural emergency hospitals to be granted a waiver from a physical environment waiver for swing beds to skilled nursing facilities from KDADs.
Well, I think we could do that now, and then maybe they'd have something drafted between now and October meeting. That would be good.
Okay.
Further items, committee? No, we'll just take and see what they come up with, and then we can make that vote then. And see if we offer introduction of a bill. So I would say, Senator Fagg, it would be my recommendation that you also get with the entities that know that topic and make sure that they're in contact with our revisers. Because they're the experts. Once we give them the information, our revisers are awesome. But someone needs to give them a little guidance on all the topics they deal with, because it's huge. All right, committee, thank you for your indulgence. I think that we've had a very productive couple of days. I think we've learned a lot of things and a lot of new things, which I think is exciting. So we are adjourned till October's meeting.